dedicated breast PET. And you could call them promising, but if they referred to a larger sample size, right now we do not really know if it is a coincidence or not, so we cannot draw data. And what about the nomograms? So I just updated the slide yesterday night, and last time I had this slide, I had written circa 50, it was 49, now it is 50. There is a Dutch nomogram, one more, in Annals of Surgical Oncology. But the thing is that these nomograms are promising in possibly identifying patients with higher risk for underlying invasive cancer. But once you remove all the high-risk features, what we traditionally consider as high risk, which is intermediate high-grade, mass-forming DCIS, comedonecrosis, necrosis, and higher size with different cutoffs, none of these nomograms retains the prognostic significance. And this kind of reflects our ease to reach a consensus about what we consider low-risk DCIS, but we do not really define high-risk DCIS adequately from the standpoint of underlying invasion. At the same time, we have epidemiological data that suggests that axillary evaluation in DCIS will affect treatment decisions, but in the end it will not affect survival. And this is not a surprise, given the fact that we actually know more or less that if we have done adequate preoperative assessments and investigations, we are expecting that the invasive cancer that we will probably detect is going to be a small one, and that will not significantly change things. On the other hand, if you do axillary evaluation in patients with DCIS, this will increase the complications, and regardless of increase of complications, it will increase the relative risk for long-term morbidity. So with other words, you may do a sentinel lymph node biopsy for the convenience of not needing to do it afterwards if you need to, but this means that your patient has a higher relative risk of 6 to 8 for chronic complication, shoulder arm morbidity, lymphedema, and so on, compared with if you had not done it. And let's go further to what we believe and what is really out there in terms of evidence. So we have been grown, I have been grown to know that you do not need to do sentinel lymph node biopsy if you're doing breast conserving surgery, because you can find it afterwards. But there is only one study until recently, interestingly, that looked into that, and this is the multi-center GATA study from France, where they saw that the detection rate at reoperation was 85.5%, and mind you, all patients had gotten their scintigraphy. It was before the Sensi trial, I guess, and the majority had gotten a double tracer. In this study, there was no information on whether any type of oncoplastic breast procedure had been performed. So for that particular but very large and emerging field of our daily practice, we actually have zero data. There is some data extrapolating from diagnostic excision. There is an excellent trial from India, the snail trial, where we saw some things, and I'm going to show them a little bit more. But let's discuss how things. So this is a lady that needs a little bit more of a quadrantectomy because she has a large DCIS in the upper outer quadrant. And some people would do upfront sentinel lymph node biopsy, and some would not do, depending on where they come from and what the practice patterns are. But the notion that after performing breast conservation in this patient, where we did a perforator flap, that you have left the lymphatic outflow intact and that you will be able to find the sentinel node is a little bit challenging, isn't it? What about guidelines? So we were curious. I was personally curious with a group of other surgeons from Sweden, the UK, and Italy, and there were actually some oncologists that were curious. So we did a systematic review of the guidelines in English languages that had specifically addressed the idea of sentinel lymph node biopsy in the setting of DCIS. And the repetitive patterns are mastectomies, and when should you consider? And you know, guidelines, there are actually guidelines on how we should be reporting guidelines, okay? And none of these guidelines complies to how they should be reported. the guidelines to report guidelines clearly state that you should not resort to formulations should be considered, maybe individualized, appropriate patient selection, and all these things that we say when we really mean, I have no idea. Okay, but what we did is that we took these guidelines and we projected them in a predefined prospective study that we were running at the same time, just to see how that would work in what is more or less universally accepted as high-risk DCIS. And that was the Sentinel study which we will be coming now. So, take a look at this. This is a study where 184 patients that were the interim analysis population from the Sentinel trial was broken down to the way that we would discuss them in a multidisciplinary meeting. So, age, size, grade, comedo, mass forming, location in the breast, possibility for breast conservation or not, and so on. And 6 blood and isolated this decision to interpret the guidelines. If we just go to the area under the curve, which is more or less how good is this guideline system as an diagnostic accuracy to make decisions, you see that it is as good as the toss of a coin. So it's not good at all. Interestingly, in this study, every patient would have as high a risk to be either undertreated or overtreated in a random manner, depending on where geographically they were located in the world. In plain English, this means that we do not really know what we are doing about that. So we went further to the experts. So we exposed 30 experts, breast surgeons, breast surgical oncologists, radiation oncologists, clinical oncologists, in the same procedure. So we used the experts in order to understand trends and patterns of decision making and to use them, their diagnostic accuracy, since what we say is that individual patient selection, and this happens on the MDM level or on the expert level, isn't it? Okay. I have not showed them the results yet. This is how it looks like. So, a very wide range of recommendation for upfronts and lymph node, a very bad diagnostic accuracy, and again, the toss of a coin. Very significant heterogeneity, but interestingly, and regardless of whether there was a pattern of the experts following the guidelines or not, what we saw was that DCIS size played a role, but there was no unanimous cutoff. I mean, the NICE guidelines, once upon a time, they said 40 millimeters ASH, isn't it? And then the ASCO said 50 millimeters. And then the Italians say 50 millimeters or multifocal, multicentric disease with many microclusters and things like that. Mastectomy was a constant yes, that we can understand. Simple white local excision was predictive of no, but it was not a constant no. And there was a higher correlation with oncoplastic breast procedures that escalated depending on the type of the procedures that you would have to do. So somebody that would just be able to solve the issue with placing an incision in the submammary, in the mammary fold, or do a periareolar incision, would feel safe in not doing it, but that was not the case, and for good reason, I think, if you thought about doing a real reduction mammoplasty, or if you would be doing a perforated flap reconstruction. Even more interestingly, all the other factors that we have traditionally been building our nomograms on played no role. Okay. If they don't kill me, we're going to publish that. So, any conclusion? Well, more or less, we do not know what we do not know. This is how it looks like, evidence-wise. And there is an uncertainty of safe future axillary mapping that is the main driver towards axillary surgery, and that is stronger than biological factors that may or may not be risk factors for underlying invasion in a preoperative diagnosis of DCIS. So we started thinking, just by mistake in the beginning, how to reverse the dilemma. So wouldn't it be nice to know where the node is, mark it, tattoo it in some way, and find it only if you need it? And this is how we landed in the Sentinel trial, sentinel lymph node dissection in DCIS, and how to not do it. So what we did there is that we had observed that SPIO, superparamagnetic iron oxide nanoparticles, stay in the tissue a much longer period, and this is something that people like Mark, who did a trial before we did the trial, saw it as something very negative as us, because we had discolorations after subcutaneous injections. But we thought about just reversing this problem to a benefit, and we saw that it stays, it resides in the sentinel lymph node a prolonged period of time. And the Sentinel study published its interim analysis back in 2019. I'm going to present the final results because I think that there is some interesting information in that. So in the total cohort of patients that would have, under the study criteria, been considered for upfront sentinel lymph node biopsy for any either surgical or biological, this policy, injecting SPIO in the breast so as to mark the node, but not removing the node, and going for a delayed sentinel lymph node biopsy only if pathology showed that you had invasive cancer, resulted in that 77% of patients avoided axillary evaluation in the long run. And looking at the detection rates, this is what I think is the most important thing. When we were talking about wide local excision, and in this study, wide local excision was also, we defined simple oncoplastic procedures without extensive mobilization as such, like a small periareolar incision, for example. But there were no surprises there. So what we knew is what seems to be the case. But when you went to oncoplastic breast conservation, and we're talking about big mobilizations, tissue replacements, and things like that, the results were as bad as with the mastectomy. And while the addition of blue dye kind of made the isotope a little bit better, it was still low to unacceptable levels. Going further, we saw also that there was a difference in nodal detection rates and the number of nodes retrieved. And don't get me wrong, I don't think that there is anything wrong with the isotope and the blue dye. It is just that we are injecting it on operated breast and scar tissues. So it does not work because it is really not supposed to work. The most interesting thing is concordance, because what we were doing until now, especially in the setting of breast conserving surgery, was that we were doing a late sentinel lymph node biopsy, and we were making our decision based on that. So you see that the concordance in this setting, especially for oncoplastic breast conservation, is very, very low. I just need to remind you here that a constant finding on all the studies that compared pairwise the isotope with the magnetic markers, the magnetic tracers, the upfront concordance was higher than 96%, meaning that if you inject both tracers in intact lymphatics, they will find the same node. So you could kind of say that the true sentinel node was the node that was marked by SPIO before disrupting the lymphatics. And since Sweden has got a state healthcare system, we have to be able to prove that everything we do is cost effective. So what we saw is that for patients that had pure DCIS, the cost containment was approximately 28%, and because of the fact that we avoided so much extra surgery that was actually unnecessary, it was cheaper for us to include patients in the study than doing standard of care. So the cost reduction was 9.8% for the entire cohort. Moving further with that, we decided to move further because the study was a feasibility study and we had not powered it for differences in detection rates, and this is what we are doing now in two separate arms, a mastectomy arm and a breast conservation arm, and we have a parallel arm like a registry that somebody might want to just put in data prospectively, just to be able to prospectively assess and investigate decision making and outcomes. Thank you very much for your attention.
Very much for your excellent presentation. Is there any questions from the audience? Okay, thank you so much, and we move on to the next speaker.
Thank you very much. The last speaker of this session is Professor Hale Çağlar from Anatolia Center, Health Center from Kocaeli. As we see from the sessions before, the axillary surgery and radiotherapy is still a debate in breast cancer. So we are looking forward to your lecture, Dr. Çağlar. Thank you very much.
Thank you very much for the introduction. Thanks for the organizers for inviting me to give my lecture. It's always good to see friends. So my initial title of my talk was Axillary Management in Breast Cancer, a Radiation Oncologist Guide. But with the permission of the organizers, I have altered my title of my talk to Regional Nodal Management because it's really very difficult to differentiate axillary radiation and the other regional nodal radiation in clinical trials. So I have roughly 20 minutes, and I have divided my talk into two major subgroups. First, I'll give some general information about the regional radiation, regional nodal radiation in breast cancer. The first subgroup is regional nodal radiation in upfront surgery setting. And the second will be regional nodal radiation after neoadjuvant chemotherapy. I'll try to focus on more recent data if possible. So being a radiation oncologist in early 2000s in breast radiation oncologist was really very straightforward because the targets were very clear. We were doing tangents for breasts or chest wall. Sometimes we were adding a third field for locally advanced diseases for high-risk patients. And the internal memory radiation was performed at the discretion of the radiation oncologist because we had concerns about some cardiac morbidity. And there were really very infrequent isolated internal memory relapses, so we didn't think that that was an issue. But as the survivals have getting more better, we have started discussing about the reducing toxicity of multimodality therapy. And the first reduction started with axillary surgery, thanks to the surgeons. But this obviously confused the medical oncologist and the radiation oncologist. The medical oncologists were confused because the decision of doing additional systemic therapy and the intensity of those systemic therapies in the past were relying on the number of involved axillary lymph nodes. But with the help of genomic profiling, now the medical oncologists are not confused anymore because they're deciding their adjuvant systemic therapy accordingly. But we, as radiation oncologists, are still a little bit confused because we have a hard time deciding where to treat and how to treat. So that wasn't easy in the past, as I said before, because we're doing either post-mastectomy radiation therapy to the chest wall, and the regional nodal areas were pretty clear. We were doing either a supraclavicular fossa and axillary apex, where the surgeon cannot reach with the axillary lymph node dissection, or can reach but does not want to reach. And sometimes we were treating the internal memory lymph nodes. So it was a comprehensive, all or nothing regional nodal irradiation approach, especially mostly in patients with N-positive disease. So I would like to emphasize from now on that the regional nodal radiation after upfront surgery and after neoadjuvant chemotherapy and surgery are different clinical scenarios. They have treatment paradigms with overlapping but not equivalent indications for regional nodal radiation and post-mastectomy radiation therapy. So the seminal trials in post-mastectomy radiation therapy and regional nodal radiation after upfront surgery were based on this three, very well known by everyone, three randomized clinical trials, the two Danish trials and the one British Columbia trial. They all demonstrated local regional recurrence benefit, disease-free survival, and overall survival benefit with the addition of post-mastectomy radiation therapy in patients with stage 2 to 3 breast cancer treated with systemic therapy. But we had to ask ourselves the question, Do those findings apply to the patients diagnosed with pathological N1 positive disease today? And the answer is no, because obviously the systemic therapies applied to those patients is not as it is in the past. So we have to decide about the major benefit of those radiations in the current, more modern systemic therapies. So as I said, the surgeon starting treating Les Axilla with upfront surgery, and the first publication published was the ACOSOC trial. Obviously, everyone knows very well about it. This included early stage clinically anzura disease. The patients were treated with breast conserving surgery plus breast radiation therapy and systemic therapy. Most of the patients were hormone receptor positive. The patients were randomized after 1 to 2 pathologically positive lymph node after sentinel lymph node biopsy to axillary lymph node dissection versus non, and that was a non-inferiority trial. And the 10-year overall survivals were no different in the two arms. Obviously, everyone knows very well about it. What I would like to emphasize is the radiation oncologist perspective of this ACOSOC trial. Because when you go into detail of the adjuvant radiation to the patients, either receiving axillary lymph node dissection or left with sentinel lymph node biopsy, was different. And this is a publication that was done after the publication of the first trial because the radiation therapies were not standardized. Some of the patients received standard tangents where 50% of level 1 and 20 to 30% of level 2 is receiving radiation therapy. Some of the patients received high tangents where 50% of level 1 and 2 can be treated with this technology. And some of the patients were treated with an additional third field lymph node, lymphatic radiation, where you treat probably 90% of the whole lymph node area. So let's go to details of this radiation techniques. In the group of patients who received sentinel lymph node dissection, addition of a third field was a little bit more than the axillary lymph node dissected group. And the patients who received high tangents was a little bit more in the axillary lymph node dissected group. So the post-operative radiation therapy was not standardized in this ACOSOC trial. Another trial which was more planned in terms of radiation, obviously, is the AMAROS trial. Very recently, 10-year updates have been published as well. Like the ACOSOC trial, they have included early stage clinical anzura disease, but in this study, mastectomy patients were allowed to be included in the study. The patients received postoperative radiation if needed, where 90% of the patients received radiation therapy and some sort of systemic therapy. The patients were randomized after sentinel lymph node biopsy to receive axillary lymph node dissection or full axillary radiation therapy. And as ACOSOC trial, this is a non-inferiority trial. So this is the trial design. As I said, the patients were either randomized to lymph node dissection or radiation therapy. The stratification was according to the treating institution or the adjuvant systemic therapy by choice. The median number of the lymph nodes removed and the size of the median number of macrometastases were fairly balanced in the two groups. Those are the 10-year outcomes. There were no difference in axillary recurrence rates, no difference in disease-free survival and overall survival, where on the other hand, axillary lymph node dissection associated with significantly higher rates of lymphedema than regional nodal radiation in first, third, and fifth year. So as the breast surgeons started to treat less and less lymph nodes, the radiation oncologists wanted to treat more and more and more lymph nodes. So by that time, 2 major or 3 major phase 3 randomized trials of doing more regional radiation therapy was published. The first publication is from the Canadian group, which was done in 2015. Which included a little bit more high-risk patients than the ACOSOC and the AMAROS trial, primarily breast cancer patients with PN1 or breast cancer patients, they were randomized to breast only or breast plus regional nodal radiation, which included level 3 supraclavicular fossa and internal mammary lymph nodes, because all of those patients here received axillary lymph node dissection. That's an old study. The median age was greater than 50%. The majority had ER positive tumors, and they received relatively modern chemotherapy and endocrine therapy. The 10-year outcomes of regional nodal irradiation versus observation ended up with increased isolated local regional free recurrence, distant disease-free recurrence, and disease-free recurrence on the advantage of doing regional nodal radiation, where on the other hand there was no overall survival benefit in the whole group. But there was an unplanned subgroup analysis when the patients were ER negative or PR negative, adding a regional nodal radiation increased the overall survival from 73% to 81%. And there were no differences in cardiac toxicity, late pneumonitis, or fibrosis in the two study groups. So this is the unplanned analysis of the this is a graphic of disease-free survivals when the patients have ER negative and PR negative tumors. The the benefit of regional nodal radiation was more enhanced compared with the hormone receptor positive patients. Obviously, this the radiation oncologists have started to think about the impact of biology on local recurrence, because in the past there were some papers which were published stating the importance, giving some feedbacks about the importance of the biology on local recurrence. For example, this is a big population-based study, included more than 5,000 patients, looking at the impact of tumor biology on local recurrence when the 30% of the patients received post-mastectomy radiation therapy with a median follow-up of 50 months. You can see that the best group is the luminal group, luminal A, luminal B, and HER2 positive that is receiving trastuzumab, where on the other hand, triple negative tumors have more tendency to recur locally. This is an important information that we need to take into account when we're deciding about the radiation indication and the radiation fields. Another study within the same group, within the same period with the Canadian is in the EORTC study, the Portman study, which included more than 4,000 patients and accrued between 1996 to 2004. They included either not positive or not negative tumors, which were located in the inner central quadrant, where 44% of the patients were lymph node negative and 60% of the patients were less than 2 centimeters in size. 76% of the patients had breast conserving therapy. The patients were randomized either to whole breast radiation versus whole breast radiation plus regional nodal radiation, or the mastectomy patients were randomized either to observation or chest wall and regional nodal radiation. So the first publication was after 10 years of follow-up, and the addition of regional nodal radiation increased the distant disease-free survival. So a local therapy was increasing distant disease-free survival statistically by 3%. And very recently, their 15-year follow-up was published, and with the addition of regional nodal radiation, there were fewer breast cancer recurrences and lower breast cancer mortality rate, where on the other hand, there were no differences in disease-free survivals, distant metastasis-free survivals, or overall survivals. And something that we were expecting eagerly to see on this publication was the long-term cardiac toxicities, because we were so concerned about the addition of an internal mammary lymph node as radiation oncologists. But when you do give modern radiotherapy technique to internal mammary lymph nodes, you're not increasing the long-term cardiac toxicity in terms of mortality and morbidity. Another Korean trial, a phase 3 randomized trial, evaluated the benefit of adding an internal mammary lymph node to mastectomy or breast conserving surgery patients. And when you look at the the whole group, the addition of internal memory lymph node didn't reveal any advantage in terms of disease-free survival or breast cancer mortality. Although the lines are not merging, it's not statistically significant. But there was an unplanned subgroup analysis for the medial and central located tumors where the addition of internal memory lymph node radiation increased disease-free survival and breast cancer mortality, especially in the ER/PR negative disease. And there was no increased toxicity in terms of cardiac, pulmonary, or lymphedema. This is a recent prospective population-based cohort study from the Danish group. It's not a randomized study, but this group treated right-sided breast cancer with internal mammary radiation, where no internal mammary radiation was done for left-sided breast cancer tumors. The median follow-up was roughly around 15 years, and the addition of internal mammary lymph node radiation increased the overall survival statistically. So another question comes into our mind because we're doing a lot of more hypofractionated therapies. Is it safe to do hypofractionation if you want to treat regional nodal radiation? And the answer is yes. This is a Chinese phase 3 randomized trial which is published last year. They have randomized 820 patients, and the local controls were the same in conventional and hypofractionated, the moderate hypofractionation, and the toxicities were equal in the two groups. So we can say that it's safe to add regional nodal radiation and do an hypofractionation. So those are my conclusions of a regional nodal radiation in the upfront surgery setting. Less axillary surgery does not deteriorate oncological outcomes. On the other hand, the patients have better quality of life, especially in terms of lymphedema. The less the surgeons extract, the more radiation oncologists irradiate, and this is a truth. More extensive internal mammary radiation increases outcomes, especially when the tumors are centrally located or have worse biology. Internal mammary radiation does not increase cardiac morbidity with modern radiotherapy techniques. And hypofractionation is safe for regional nodal radiation. Obviously, there are multiple other ongoing trials for hypofractionation with regional nodal radiation. So the second part of my talk is a little bit shorter because we have a really very less data compared with the upfront surgery. But I need to emphasize the philosophy of radiation oncologists trying to decide where to treat when treating patients after primary chemotherapy. Nodal disease after neoadjuvant chemotherapy represents a population of cells resistant to chemotherapy and is more aggressive than nodal disease found after upfront surgery. In patients with positive sentinel lymph nodes, rates of non-sentinel lymph node positivity range from 50 to 70% after neoadjuvant chemo, where on the other hand, it's less in the upfront surgery trials. Positive sentinel lymph nodes after neoadjuvant chemotherapy, even its isolated tumor cells or micrometastases that are predictive of additional non-sentinel nodes containing cancer, and auxiliary treatments appears warranted. So this is the major philosophy that we think. There are several retrospective studies of local regional recurrence in patients treated with a neoadjuvant chemotherapy, but there are no published randomized controlled trials of radiation following neoadjuvant chemotherapy. And we rely heavily on traditional indications for radiation in patients treated with upfront surgery. Majorly, we treat those patients, the studies included regional nodal radiation. So those are the factors including radiation decisions following neoadjuvant chemo, the pre-treatment factors, the treatment factors, and the post-surgical factors. I would like to go into details of those. The pre-neoadjuvant chemotherapy factors is the most important thing. We mostly rely on these factors, especially when the primary T stage is high, or when there is bulky lymph nodes, clinical N2 and 3 disease, or when the patients are stage 3, whatever response they give to chemotherapy, we tend to do postoperative radiation therapy to those patients. Obviously, the most important thing is now to stage the axilla before the primary chemotherapy, different from the ACOSOC or the AMAROS trial. We need to understand clearly of the tumor size and initial nodal disease, because it's important for radiation oncologists to decide where to treat after neoadjuvant chemotherapy. So the patients have to go ultrasound of the axilla, probably with a biopsy, and we need to image the chest and the neck is also helpful. And we ask ourselves this question: would this patient have been stage 3 or PN2 or N3 if this patient received an upfront surgery? We always ask ourselves to this question. The neoadjuvant chemotherapy and post-mastectomy radiation therapy and the prognostic interaction between these two was analyzed in a pool analysis. Obviously, this is a retrospective analysis. It analyzed 817 patients with modern neoadjuvant chemo and mastectomy. 5 years of endocrine therapy was recommended for the patient, and trastuzumab was given to the majority of patients with HER2-positive tumors, and 5-year local regional recurrence benefit with the addition of radiation, particularly among the patients with clinical T3, T4, or clinical and positive disease, even if it converted to YPN0. So this is an important information for us, but there was no impact of radiation on the disease-free survival. The second factor that we take into account when deciding radiation is obviously the tumor response and the use of adjuvant systemic therapies, where more and more adjuvant systemic therapies are being done when there is a residual disease after primary chemotherapy, primary systemic therapy. PCR obviously is a prognostic factor. We trust this, especially in the patient's population when there is a triple negative and HER2 positive disease, not in the hormone receptor positive as it is emphasized in the bad biologies. And the local controls are so enhanced by this information as well. So this is a rough philosophy. When the patients are clinical N2 or higher, or clinical T4, or YPN2 or higher after primary chemo, we always treat those patients with breast post-mastectomy radiation and whole regional nodal radiation. If it's clinical N1 and it's still YPN1 after the primary chemotherapy, we always treat those patients. But we never treat patients who were clinically N0 and YPN0. We sometimes treat patients with clinically N1 and YPN0 according to the tumor biology. This is a very important paper. Obviously, everyone knows about it because it was published in 2012 from Mamunas. This is the evaluation of the predictors of local recurrence after neoadjuvant chemotherapy. Age is an important factor, clinical tumor size, clinical nodal status, but also the nodal outcome after the primary chemotherapy is one of the most important factors. So this is the outcome of the patients who were clinically N1 and who remain N positive, either with a lumpectomy or with a mastectomy, with elder stages or with small tumors, higher tumors. It doesn't matter. If the lymph node is positive after primary systemic therapy, the 10-year local recurrence rates is around 14 to 22%. But if the patients become N0 afterwards, the 10-year local regional recurrence rates are less. So obviously we need to take this into account when deciding where to treat. And those patients usually recur from the primary breast or the chest wall, where on the other hand, when N-positive patients usually recur not only from the primary breast and the chest wall, but also from the regional nodal areas. So what do we understand from this? The current standard of care is that clinical N1 disease that remains N positive will benefit from radiation to the breast or chest wall and regional lymph nodes. Although numbers are small, neoadjuvant studies indicate that the rate of local regional recurrence in clinical N1 patients who become N0 is generally very low. Most recurrences among N0 patients appear to be in the chest wall or breast and suggests regional nodal radiation will not be necessary. Nevertheless, there will be some group of patients who become N negative with triple negative disease and additional high-risk features like residual invasion in the in the primary breast, young age, lymphovascular space invasion might benefit from a regional nodal radiation. But obviously, we'll see this, the answer of these questions with the publication of this NSABP and RTOG trial. The treatment factors related to radiation targets and timing is important. Surgical management of the axilla is important. I know that you do want to less and less surgery to the axilla even after primary chemotherapy. So if the patients still are N positive after sentinel lymph node biopsy, either we need to do an axillary lymph node dissection or an axillary lymph node radiation. We'll see it. The Alliance trial, as far as I know, has been closed and will be published very soon. So I don't think that we will have a lot of time to wait. If the patients are clinically N1 and turned into lymph node negative with a sentinel lymph node biopsy, what are we going to do? Well, we don't know because we do not have a dedicated clinical trial answering to this question. Maybe we can look at the subgroup analysis of the NSABP. But what do we do really as radiation oncologists? If 2 or more sentinel lymph nodes or clip nodes are removed and no further axillary lymph node dissection is done, even if there is an isolated tumor cells, we treat the axilla. But if it's N0, we do not do radiation if PCR is in the breast or the patients are old with hormone receptor positive disease. But we consider regional nodal radiation if the patient is young and has a bad biology. But if less than 2 sentinel lymph nodes are removed, there are no clip nodes and no completion of axillary lymph node dissection, we always give regional nodal radiation. So, breast cancer is so common and there are longer survivals, so we need to take care of the treatment toxicities. There has to be less, but local regional recurrences are still an issue. We need to decide tailor-made decision-making process for the local regional treatments as well, looking at the tumor-related and treatment-related factors. But everything relies to the shared decision-making with a multidisciplinary approach. I thank you for your attention.
Thank you, Dr. Çağlar, for the excellent presentation. I think you have covered, every meaning of the subject. We're out of time, so we can have only 1 or 2 questions. Please, Dr. Kastakis.
Let me go back. Yeah.
How old is old and how young is young?
Sorry?
How old is old and how young is young?
Yeah, that's true. No. Well, probably 50, looking at the Mamuna's paper. Probably, but age is not a sole factor. We are combining the other factors. Like, it could be 55 with a bad biology and lymphovascular space invasion. Although it's over 50, we might decide to do a radiation. So it's like all tailor-made, and those are relying all for retrospective data. So one day decision cannot be the same as the next day decision, and we see it in our tumor boards as well. But until the time that we have prospective data, this is going to happen, I guess.
Thank you very much.
Can I make a small addition? The age is also debated, as you know, in the accelerated partial breast radiation. In the studies, we took 65 years. But nowadays the mean age extends to nearly 90s especially in the civilized countries. So this 65 years even or 60 years is debated. So the biological age, I think, from now on we have to talk.
Yes, this is the point that I wanted to lift, because I mean, if we discuss omission of radiotherapy in the upfront setting, we had the CALGB trial with the 70s, and now we've got 10-year data from the PRIME 2 with the 65s. And there is Swedish data. omitting safely after 60. So I think that it's going to be very challenging to find cutoffs, and biological age will be the way to go, I think, as well.
Probably the life expectancy has to be taken into account. That's what we do with the prostate cancer patients. Not the age, but the life expectancy of the patient will be more important.
For your excellent, detailed, extensive presentation. So I have a quick question. Is there any difference in your radiation fields in a patient with YPN positive disease treated with sentinel lymph node biopsy alone versus YPN positive disease treated with axillary lymph node dissection?
Yeah, sure. Yes, of course. In our clinic, yes. When the surgeons perform axillary lymph node dissection, we do not intend to treat the axilla which has been dissected with an additional portal to that area. Obviously, with the tangents of the breast or chest wall, a part of the level 1 and 2 axilla receives radiation, but we do not do full radiation dose there. We do not contour this area as a target. So what we do is our surgeons are doing an axillary lymph node dissection, and they're putting a clips on the top notch where they're doing the axillary lymph node dissection, and we contour on the upper part of that area. So this is what happens in our clinic.
But I think this is a subject under discussion in your field. I'm not radiation oncologist, but all radiation oncologists.
No, that's true. That's true.
radiate
Some of the radiation oncologists would like to radiate everything, but that would definitely
regardless.
increase the lymphedema risk with no proved outcome, oncological outcome. So we have to take this into account as well. But however, you want to avoid the axillary radiation in the dissected area. It's inevitable because of the radiation biology that the radiation will go there.
Okay, thank you so much. And regarding the age, we have found 45 patients younger than 45 were more likely to have a local regional recurrence in our neocentric trial.
There is not a
that we
clear
presented.
cutoff, but like when you look
Yes.
at the publications, it's like a constitutional prognosis.
It may change, of course.
Yeah,
with-
30
with
is
the
better
final
than
result.
40, 40 is better than 50, like in the real world as well.
I always admire the radiation oncologists, adhere very much tradition. You didn't left anything from tradition, or as we see your presentation, you wrote there multidisciplinary team working, but always in our also team, radiation oncology didn't change anything. But as a surgeon, we adapted a lot. So you need to change something more. At least what I say, you could say we don't know, but you don't need to say we should do. If you say we don't know, maybe some patient didn't want it.
That's true. In terms of regional nodal radiation for the upfront surgery patients, I think we're pretty clear. We can say that we should do this. But for the group of patients receiving primary chemo, we really don't know. And obviously we're over-treating in a subgroup of patients, which we don't know who they are. We need to find those patients. And there are some ongoing trials about genomic profiling in the decision-making process of radiation therapy as well. Probably that will lead us in a better way.
I think the genomic profile will give. In the last San Antonio, there was a trial which included 16 genomic payload, I think, and it showed us that according to this genomic profiling, that we should consider the local recurrence rates. So maybe in a few years, I think we will go your way.
I think, thank you so much, and thank you so much to everyone participated in the session. So we close the meeting, we close the session. Thank you.
Ashutosh Kothari. Mr. Kothari he is currently lead surgeon and chair of breast cancer tumor group as well as multidisciplinary team at Guy's and St. Thomas Foundation and Guy's Cancer Center. He is also senior lecturer for the Faculty of Life Sciences Medicine, King's College, London, and he is vice chair of Education and Training Committee, European Society of Surgical Oncology, and he is also serves an examiner for European Board Certification Examination in Breast Surgery. Today, he is give a talk about margin management and intraoperative specimen tomosynthesis. Stage is yours, Mr. Kothari.
Thank you. So good afternoon, everyone. Don't fall asleep. You just had lunch. It's not a very interesting topic, but I'll try and make it interesting. So these are my disclosures, and of course you can see CupTech there. The reason why CupTech is there is because they sponsored this conference, and so I'm obliged to mention that they're sponsored this thing. So it is a partially sponsored talk. Now we know from this paper, which was published, you can criticize it for many reasons about propensity score matching and how authentic it was, that breast conservation is now becoming more and more fashionable. Whether it saves lives is a question that we need to debate outside this room. But the evidence is moving more and more towards let's do more breast conservation, less mastectomies, because definitely it does affect quality of life. So from that perspective, at least, that's what we should be doing. Now, if you look at this, when you do breast conservation, you have a conflict of interest. You've got the cancer there. You want to kill the cancer, but you want to save the pretty breast. You don't want the breast to become disfigured because you've killed cancer. So aesthetics is becoming more and more important because quality of life is becoming more and more important. Patients are living longer, and they demand that quality of life. And remember, we're now living in a world of social media. So if you're a surgeon that gives poor results, then the world will get to know about it. So what do we mean by margins, and why are margins important? We know from all the studies that have been done that if you have positive margins, you're at least 2.4% more likely to have a recurrence. So if you have involved margins, now we can argue about 1 millimeter, 2 millimeter, no ink on tumor, but at the moment the consensus is 2 millimeters for DCIS and no ink on tumor for invasive. And if you have invasive and DCIS, then the invasive margin counts. So that's no ink on tumor. When you consider an optimal margin width, what are you actually saying? You're saying that as far as I can see, there is no evidence of disease at the periphery of the tumor. Now, if you ask any honest pathologist, they sample a very small percentage of the whole tumor. So what they're telling us is there is no gross disease, but we know from the studies done by Holland et al. Way back in 1980s, when they did a specimen of mastectomy specimen slicing, that at least 40 to 50% of patients who were suitable for a lumpectomy had more cancer in the breast, and that cancer was not clinically apparent. So you've done a lumpectomy and you've cleared that cancer. That doesn't mean that there's not more cancer in the breast. And that is the sad truth. But even then we know breast conservation works. And why is that? It works because of radiation therapy and because of systemic therapy. So if you look at any data about what positive margins are, you can argue that in my institution is 1%, your institution is 2%, but this is published data. And it varies anywhere between 12 and 23%, depending on what you're seeing. If you're looking for invasive cancer, looking for DCIS. So you are going to go in for a small number of patients to go back in and do a re-excision of margins. That means second surgery. That means more tissue taken. That means poor cosmetic outcomes. So 50% of re-excisions, when we do them, we don't find more cancer there. So you've done, let's say, 20 more operations, and 10 of them were needless. So are there ways of knowing which ones you can go back in and which ones you don't need to go back in? And that's why we come to intraoperative imaging, because there are lots of ways of looking at it. There's lots of AI-guided stuff. There's lots of new stuff. We published on Cherenkov illuminescence imaging, which is the first study ever done by humans, but it's radiation. You've got histolog, you've got AI that looks at margins, you've got margin probe, you've got clear probe, you've got lots of things, but the simplest thing is a specimen X-ray. So the benefits of intraoperative imaging are, if you do it intraoperatively, and I'll show you data to show this, it reduces your operating time, it ensures the tumor is completely removed, and more importantly, we are now living in an era of clips, and we spoke in the morning, clipectomies, wires, seeds. You have to show that the seed is actually removed. you can document in your operative notes and say, I put a seed in and I took it out. Now, will that stand up in court as opposed to I have a specimen X-ray that says, this is the specimen, here's the seed, it's out. So there is a medical legal implication of what we're doing as well. And this is the study I was talking about. So if you do intraoperative specimen imaging versus standard, so you send it to the radiologist, you save time. And it's almost as good because the surgeon interprets what he wants to see. So surgeon is interpreting, not a radiologist telling you go back and take this margin. You've done the procedure, you know where the margin is, and you're going to excise it as a surgeon. So this is intraoperative specimen radiography, margin assessment tool in breast conserving surgery. Is there enough data? This is a retrospective study, and the slides were given to me by the company. 470 cases. Standard radiography was performed in two views. They assessed about 282 margins. Obviously, if you multiply 6 margins by 8, 89% of the margins were positive, negative, 11% were positive. And standard radiography identified 77.3% of the negative margins, and 11.37% of these margins were clear, but the surgeons thought that they were positive. So they reduced the re-excision rate by 37% by this data. And this is now standard imaging I'm talking about. So then, why is this new machine good? Now, I'll be very honest with you. In 2019, our Faxitron broke. And I was thinking, should I buy a Faxitron or should I buy something new? And this company came along and showed me how it works. And I thought this makes sense because I'll show you a video and you'll understand why it makes sense. Costs a little more. So in 2D, what you do is, let's say you have this and you have this. In a 2D, this appears like a cross. Whereas in a 3D, or tomosynthesis, why tomosynthesis works in breast is it gives you a clarity of depth. So it gives you a 3-dimensional view. And that's why instead of creating a planar projection, it gives you a 3-time projection of what the breast will look like. Margin shaves you can do. So I know it was Judy Bowie who published that simple is do lumpectomy and then take this margin, this margin, this margin, this margin, and take most. Why not just do a wide local excision properly? If you don't do the wide local excision properly, you get, as you know, you take more tissue. The problem is now trying to balance what I showed you the second slide, trying to balance between wide local excision, what is adequate and what is enough. If you wanted to do a wide local excision, a mastectomy is the best wide local excision you can do. But you don't want to do that. So you want to do a nice lumpectomy. You want to do an oncoplastics procedure. You want to perceive aesthetics. So there has to be a trade-off. And that's why margin shaves, in my estimation, is slightly overkill. It does reduce it by 50%. There's no argument there. So this is another study which looked at intraoperative margin assessment for breast conserving surgery. And what they found was frozen section, because most of the people do frozen section, and they find that their margin rates, re-excision rates come down dramatically. Yes, there is no argument, frozen section is good. The problem in the West, especially after Brexit, is we are a very poor country. When I say we, I'm not talking about India, I'm talking about UK. We don't have intraoperative assessment, we don't have enough pathologists, we can't do it. We can't do imprint cytology, we can't do frozen section. And even when you do frozen section, your pathologist is not going to do a frozen section in 360. He's going to give you the closest margin, or she's going to give you the closest margin, and you say, oh, I'm worried about this margin, and they'll do it. But what actually happens when you freeze tissue? So all these happen which we don't know about, but the pathologist knows about this. So let's say if you're doing it for post-chemotherapy, and you wanted to do receptors, freezing the tissue actually can change the receptors. If you have a small specimen and you freeze it, it could damage the final histopathology report. Now, all this doesn't happen routinely, but it may happen, and you just need to be aware that when you're doing all this, you will save time and you will reduce your margin rates, but there is a cost, there's a pathologist sitting there, and you still have to rely on the final histopathology. So this is what I meant. Let's say that is the skin, that is the muscle, you've done that excision, or that's the skin, that's the muscle. Your tumor is sitting at that margin. When you look at the X-ray, that's how it will look. Because this is what you will see, and in the middle of that you will see that. So that projects there, and that is what you'll see. So if you look at this margin, it's clear. When the pathologist reports back, they'll say, sorry, you got tumor there. So this is why 2D is not as good as having a 3D. In 3D, what you can do is you can slice through each of this and know exactly which margin is involved, and that's why I know that I have a positive margin I need to re-excise. So this is the benefit of 3D tomosynthesis. So it reduces the incidence of postoperative positive margins by intraoperatively guiding you that you need surgery. And it reduces the time, also reduces the number of the healthy tissue that you remove, because all you need to remove is that bit of tissue. You don't need to remove the whole margin there. And here, especially where it's the thickest, you don't need to remove that margin. So it's more of guided precision imaging. So in precision oncology, now we're in precision surgery. This is what the machine looks like. So it's out there. Please go and see it. I won't describe it and waste your time. So this is the data given by Mozart. It reduces re-excision by 50%, and these are the papers that show that. It preserves healthy tissue and has better cosmesis. Obviously, if you remove less, there's less to replace, less to repair. Improves surgical throughput. That means it reduces operating time. So you get your patients, this whole acquisition. So basically what I do is I take this lumpectomy, and we've had this machine from 2019, mark it, and send it off for your specimen X-ray. By the time you mobilize the tissue and everything else, the specimen, the images are ready. And it's a one-time cost. So it doesn't have any expendables. You know, you have lots of machines, like you have specimen MRI scans. You can do a specimen MRI scan. Every time you do one, it's costing you £500 because you have to buy a special cassette. So every patient, you're not saving money, you're actually spending more money. And this is a recent study which was published by the UK group of Phil Drew. And they also showed a 41% reduction if you use 3D versus 2D. So there is data out there. It's not randomized control. Everything doesn't need a randomized control trial. Some things need common sense, and I think, as we said in the morning, surgeons have the most common sense. So you have to make up your mind and say, does this work? Does it make sense it works? Like when I went to visit Andreas and he was doing the Sentinel trial, I didn't need the data to come out. I knew that what he's doing for preserving the sentinel nodes is absolutely makes sense, and we started doing that. So we're now publishing our series of 21 cases. 21 cases of DCIS where we used mastectomy, where we used MAC trace. We've never gone back for one node. So in 21 patients, we've saved the axillary lymph nodes. So this is what your clipectomies look like. Now, if you look at this paper, there's no data on post-neoadjuvant chemotherapy of whether 2D is better than 3D. And the question is, in pre, you have a sensitivity of 19% and a specificity of 89.2%. The rate of secondary procedures hasn't reduced dramatically, but has reduced quite a bit. So to save one re-excision, you have to do 25 operations, basically the intent to treat. And this is more because with neoadjuvant chemotherapy, it's very difficult to get margin assessments. And that's true whether you do PET CTs, MRI scans, or CT scans. So these are the benefits of your Mozart. And it also has things like if you go outside, it's got voice commands. So if you're a surgeon, all you have to say is Mozart zoom in, Mozart zoom out, Mozart 3D, Mozart 10 cut, and it'll give you all that. It's like Siri. It's like having an iPhone. So the machine does exactly what you tell it to do. It's got a list of commands. It teaches you what to do. And it gives you very, very good high resolution images. They've just added a new sentinel node biopsy probe to it, so you can play around with that as well. And this is the video I want to show you, if it works. So this, when you put the specimen in the cupboard, it takes a picture like this. And this is obviously an inked specimen, and we also put stitches to show what the ORTC marking is. And then what it does is, let the machine do it itself. This is how it goes all the way down. So you can see the image. Every 1 millimeter cut it's giving. And then comes back all the way to the surface. And I'll use the same case to show you how it helped us revise the margins. So this is just the optical view and the overlay of the specimen. So you know exactly which margin is where in your mind and orientation-wise, and then you know how to re-excise it. So let's do a case study. In our hospital, like I said, 2019, we did it as more of a common sense thing. We thought, yes, newer technology will help us. It has helped us. We've used it for more than 400 cases. It decreased our re-excision rates. We haven't done the analysis. It's being done. We hope to present it very soon at the next ABS. So this is the case study, and if this voice works, where is the thing? Yeah. Sound should work. has a voiceover, so I'll just shut up. Why is the sound not working? Okay, so this is, I'll tell you what this is. Basically, this is, if you look at it, there's your X-ray clip, there's your localizer max seed, and there's your microcalcification. So in the 2D, you think this has been completely excised. Okay, now let's look at it in 3D. So this is what you're seeing. Specimen, that's the lesion, and in a 2D, you would have said this is completely excised, I don't need to do anything else. Why is it not talking, this thing? But that's the truth of what actually is going on. The lesion is there. It's more superficial than the planar view. There are subtitles there as well. So whether you keep it straight or when you move it sideways, it's still going to show you the margin is completely excised like that in a 2D view. Let's move it on. So now we come to the 3D, which is the cup deck. So each slice has its own margin. So you know exactly at what depth you have a positive margin or a negative margin. Yes, you can actually tell you what millimeter slice you're in. The machine will do that for you, and it shows you on the screen what depth you're at. They're trying to sort that out. So they're trying to get a specimen holder that holds the specimen, because exactly what I said to them is compression. So the pancake phenomenon happens, yes. But it'll happen to less than 2D. So there's a case now that we'll show you. So this patient underwent clip, that is the marker clip, and she had classifications. So if you look at the first slice, there the microcalcification, slice 0. So it is at the margin. At 0 millimeters, you have microcalcification, you have the clip, and you have that. Now, if you took a specimen X-ray of that, you'd say I've excised it completely, because you're looking at the radial margins. You're not looking at the anterior margin at all. Now you know from that slice that the microcalcification will slowly fade away, and as you go deeper, there's no microcalcification from slice 7. So it's about a 7 millimeter thick area of microcalcification, but the anterior margin is involved, which you can only tell if you did this. So if you did 3D analysis, you know, because this is slice 0, you shouldn't be seeing microcalcification in slice 0. Here, you don't know what slice it is, so you think it's completely excised, and this is why we think it's better than having just a simple 2D. So if you had this, you would re-excise the anterior margin if there is no anterior margin to excise, because we know again that if you go from skin to muscle, there is normally no more anterior margin, but at least you're sure. You're not sitting in the operating room, in the MDT afterwards, scratching your head and saying, did I take out the anterior margin? I don't know. In theater, you know you've taken anterior margin because that's all that there was to take. So if we did that, we know in the system, and that's, thankfully that's over. So it's a long, thank you for sitting through that video. So in summary, specimen X-ray, we use intraoperatively. We use a lot in the UK, especially for screening. If you're at a screening center and doing screening mammography, needle localized, wire localized, you have to take an X-ray. With the new seeds, you're still going to take an X-ray. So you need an X-ray. You want a 2D or a 3D? If you're intelligent enough, you should know. It doesn't cost too much more. It costs about 20 to 30,000 euros more than a standard faxitron. But the cost afterwards is zero to you. The company's got very good, every time they upgrade the software, they come and give you the software for free. So all the voiceover and everything is, in our machine, we didn't have it, but they've installed all that software. It's more like the Tesla car. It does online. Every time you log on, it just updates the software. And reduces operating time, reduces reaction rates, and I think I've told you enough. So if there are any questions, burning questions, I can answer them. And I have to thank CupTech for their sponsorship.
Thank you, Mr. Kocaeli. Nice presentation. So is there any question from the audience?
Actually, if you look at the United States series, excision rate is 1 in 4.
Yes.
Yeah. But in Turkey, we like to finish in one session, so our margins are not so involved. So, and our also local recurrence rates are very low. So this is maybe image-guided, image tailoring surgery, surgery and pathology together with, we can solve the problem.
So this is
Without
more for
image.
non-palpable lesions, post-neoadjuvant chemotherapy, if you have microcalcifications, to know you've removed all the microcalcifications. It's not for every case. It's not for palpable tumors.
This is
for
the
sure.
only case
No.
is helpful for microcalcification.
And if you have a screening program, if you need local wire-guided excisions to know exactly whether you've removed the tumor or not. So, yes, so it's not for everyone.
In your practice, are you using
Ultrasound.
marking for specimen orientation
Yes.
routinely?
So EORTC.
What kind of markings? It should be radiolucent and also. And
So if we don't pay, so for certain studies we had to paint it, so that was part of a study, so we painted the specimens intraoperatively. When we don't paint them intraoperatively, we use one, so this is EORTC, it's not me, one anterior. So it's one anterior, two superior and three lateral. One anterior, two superior and three lateral.
How do you find the positive surface leaving behind the breast?
So again, if it's DCIS, you won't find anything. If it's post-neoadjuvant chemotherapy, you might find some fibrosis. So it's very difficult, depending on each case, what you actually see. But grossly, this is microscopic, so you won't see much on gross or feel anything, because most of the women who have breast cancer at screening age are 50, 55 and plus. So fatty breasts.
In my practice, I'm doing always frozen section analysis because I'm feeling comfortable.
Yes.
If you work with good pathologists.
That's why I showed you the data. Frozen section does reduce it, yes.
Intraoperatively, if you take the specimen with 3 and 4 different aspects mammogram, the same thing.
You will still have the same problem. So the projection problem is going to remain. Because no matter what you do, you're still getting a 2-dimensional view of a 3-dimensional organ. So that whether you keep it straight or you keep it sideways, you're still going to get that projection artifact, which you can only see if you have slices.
Oh, nice.
Thank you for the questions. One question from me. Do you have any satisfaction score used by surgeons? Have you ever used this?
I don't think there's no paid surgeon satisfaction score for the technique.
What did the surgeons said to you? What's the interim feedback after they use CubeTech?
The machines are more in the US, so I don't know whether there's anyone from the company who can give us the US feedback. But I'm using it, and I think it's much better than Faxitron.
Okay, so one additional comment. When you are using this tomosynthesis, you are looking at the machine, but you are on the table, surgery table, and you are looking at like this. So it doesn't give me directly where I am, how I can remove the correct correct margin or correct problematic site. So for this,
It does. Just let me stop you there for a second.
Not really.
If you put marker clips, you know
Yeah.
exactly what margin is involved,
So,
and you can take it out. So
there
this is not
there's
guesswork.
an invention, new invention
Called
in USA
Yeah.
that I have a glass and I'm checking the tumor bed. They are using tomosynthesis, and they are checking the tumor bed, and in the tumor bed they can see the cancer there, and then they are removing it.
Yes,
So-
I was at ASBRS. I saw that.
Yeah, so
And if you believe that, you believe anything.
yes, so it's gonna be the combination, and it's gonna help your study, I think.
So
in the future.
so if you were ASBRS, there was MRI scan, there was PET CT scan, there was CT scan, and there was margin assessment, and
Yeah.
all of them said we are better.
Okay,
So yeah, you have to believe what to believe.
okay. Thank you.
Thank you.
Yeah.
The next session, Dr. Arıcan Müslümanoğlu, the chair of session.
Good afternoon, everybody. In this session, we are going to discuss plastic approaches of the reconstruction. There are really two distinguished speakers. One of them, Burcu Çelet Özden. She's our really most good doing surgeon. We love her very much. Yes, go on, Burcu.
Good afternoon. So as Dr. Kotari said, the afternoon session after lunch is certainly a challenge since we are all struggling to keep awake against the postprandial lethargy. So I will try to make it colorful and full of technical videos as I give a personal overview of DTI reconstruction with different pocket sites, various soft tissue substitutes, and implants of different surface properties. So the introduction of soft tissue substitutes has become a revolutionary step in my personal breast reconstruction practice. And when of prosthetic breast reconstruction itself, we can say that we are living a back to the future situation, like we are closing the loop by once again moving our implants from under the restricting effects of the muscle to a more natural epipectoral plane. But this time with a lot more success than the ancestor technique of subcutaneous placement, which is essentially the same plane but not the same pocket, as it has historically been associated with high rates of complications and implant loss. So what is the difference that makes us think that the new pre-peg technique will be and actually is more successful? I believe the most important one is that the change in the mastectomy technique itself, thanks to you, breast surgeons, with better perfused flaps, the thickness of which are determined according to the anatomy of the individual patient. It is indeed this change in the resection surgery that has allowed us to talk about success in any kind of implant-based reconstruction. But also it is the fact that now we are finally talking about the bioengineered breast concept with three major components: biologic scaffolds, patient's own fat, and new technology implants. And these three are the cardinal factors that serve in synergy for a high yield outcome in modern breast reconstruction. I'm still learning from you, Dr. Kotari. He was my jury in the breast board. So the switch from evolution to revolution, if you will, came with the introduction, as I said, of ADMs, which have truly changed the whole game of prosthetic breast reconstruction. It has certainly improved my showcase. It really hurts me to even look at the photos from back when I had to place my implants under the muscle. Today, we are fortunate that we are better able to get results that look much more like breasts than we were in the past. And soft tissue substitute market gets more crowded every day with a new product introduced almost every month, claiming to be the best And honestly, I have this love and hate relationship with all of them because of the obvious advantages as well as the downsides, turning them into expensive bombs if not used in the proper setting and patient selection. Okay, so what do we have on the market? And as I said, it does get more crowded every year, but basically we have the biologics and we have the synthetics. Overall, it seems to me that the plastic surgeons seem to prefer the biologics because we see these patients down the road. We get to deal with the softness and katkının issues, and in this regard, ADMs serve us better. Breast surgeons doing recon, on the other hand, are more practical. I like to get it done with synthetics, which are obviously cheaper and somewhat easier to, at least in where I live. Synthetics are also stronger, providing a radiotherapy compatibility seems to be the same with both groups, although there are reports of the protective effect of the capsule modification provided by the biologic ADMs. Seroma, again, is a very real problem with both groups, although integration issues are more often observed with biologics, as is the red breast syndrome, which has multifactorial etiology depending on the product and the host factors as well. So in the beginning, when we did not have ADMs, I've used permanent meshes, and I ran into trouble because especially in patients with thin flaps, they fistulized through the skin, and once they got infected, it was very hard to clean them off the pocket, eventually causing a large area of skin loss. I also got referrals from my colleagues with more extensive mesh complications. These required flap surgery. So for the past 5 years, I've been doing mostly direct-to-implant reconstruction, although I should say that expanders still have a place in my practice, especially now that the neoadjuvant population is growing with adjuvant radiotherapy, usually necessitating a two-stage approach for at least the revision and restoring the radiotherapy effects. Again, I have not completely switched to exclusively pre-PEC, don't get my message wrong. Dual plane combining muscle with ADM still has a place in high-risk patients, especially with the DTI approach. Until the last few years, we did not have many choices for biologic substitutes. Human ADMs are not allowed where I practice, but now we have quite a bit of competition on the local market as well. And our choice has been the German brand of a bovine pericardium product. It's called Tutopatch. It's expensive as the fancier pre-cut or pre-meshed versions, and it's been almost over 1,000 breast reconstruction in about 671 patients with fairly low complication rates and consistent results over a reasonable period of long-term follow-up in my series. In dual plane, I release the muscle inferiorly. I don't go from a lateral approach because I want the hammock effect. I hydrate the ADM before use. It's a brief hydration. It's not like the human ADM. And I hydrate it with a triple antibiotic solution. The color from betadine, we don't use betadine, but it's the rifampicin that gives this scarlet color. And I mesh before I cut the 14 by 20 piece in half for bilateral cases. There's this debate also over mesh versus non-mesh. We mesh to increase surface area as well as to prevent any seroma fluid adjacent to the implant. But then there seems to be a trade-off, since the more aggressive you mesh, the more fibrosis you get in your capsule. So I now just fenestrate and not mesh extensively. And more recently, it has been suggested that with the whole wrap pockets that come non-meshed at all, that the product is left unmeshed to prevent the seroma fluid from getting in contact with the implant wrapped inside. Well, I have doubts about this. I don't see how this suture closure would be watertight. Although I have just recently started to use the product, I traumas with that as well. And in this case, they have to be drained percutaneously since they are not in reach of the drains. So going back to the dual plane, I believe one other thing to prevent seroma is to limit the contact of the product to the skin. So I use drapes and I apply the same 14-step principle of minimal manipulation as we do with our implants. I sew in the material in a semicircular fashion, first covering the IMF, and then I extend it simply over the implant to stitch to the edge of the pectoralis muscle. I routinely refresh the edges and try to get a well-vascularized dermal barrier over the ADM. I think this is crucial as well. This is a unilateral case. With bigger implants, obviously, a larger area is covered by the ADM. So basically, it becomes a pre-PEC pocket. So we can see the natural ptosis with good symmetry, but we also have to be aware of implant malposition over time. I will talk about later, since the ADMs do tend to stretch, they don't support as much as the synthetic counterparts. Previous radiotherapy patients are a red flag, and I use ADMs sparingly in this group because it does not integrate well. This is an example. This is a patient who developed cancer over her subglandular implants for cosmetic purposes, and then she got a lumpectomy irradiation over her implants, and a few years later came back for a bilateral prophylactic mastectomy. We did a pre-PEC reconstruction with anterior cover ADM, thinking that there was already a space over the muscle, but obviously it did not vascularize, causing seroma, so we took out the implant, put back to buy time and get rid of the infection, and then she went on to get a latissimus flap to further salvage the reconstruction a month later. So now if I see these PETA signs, which are the pigmentation, telangiectasis disease, atrophy, fibrosis, the adverse effects of radiotherapy on the chest wall, I don't go for implants, let alone ADMs. I just offer flaps or a hybrid reconstruction with a latissimus. If the chest wall skin is not affected, on the other hand, I do a DTI, but using very little ADM and a cuff of the muscle as well. Expanders don't work well in my hands with these patients. We cannot expand this fibrotic irradiated muscle. It's very painful, but then the skin is not so well vascularized to further revascularize a big piece of ADM either. So I found the dual plane DTI technique to be kind of a trade-off in order to minimize the complications in this group of patients. And recently I have started using the polyurethane coated implants. With careful selection, I think it just works beautifully as well. So this is one such patient, previously irradiated, found to have a BRCA, so went on to get a doublectomy. We don't see much of the PETA signs on her right breast, which had been irradiated. So we went ahead and did a dual plane DTI and could get away without complications. Another patient, previous radiotherapy on the right side, dual plane DTI. At 5 years, she came back. You can see the asymmetry settled. She asked for a revision and an upside. With some fat grafting and a bigger size implants, we could get this result. So what about post-mastectomy radiotherapy? It's I'm glad that Haya has left. It's a major factor affecting our final outcome. But over time, what we have observed is when there is less muscle and more ADM covering our implant pocket, these are all my cases, and incidentally, the I found after radiotherapy are significantly better. Because when the implant is not affected by the irradiated muscle, as in a pre-PEC, you can see all three techniques here, and the radiotherapy on these different pockets, then you don't get migration. In a pre-PEC pocket, all you see with radio some fat atrophy, but the pocket is not affected by the fibrotic muscle, which gets further contracted, and the implant gets migrated in a subpectoral technique. So we've been irradiating our pre-PEC implants with acceptable results for quite some time now, such as this patient with traditional gel implants. We follow the patients with 3D simulations and have a objective marking of the nipple areola, and we can compare the migration. Or this patient, you can see in the mid column, this is the result before radiotherapy, and on the right-hand side, on the left-hand side, you can see the result 6 months after radiotherapy on the right side, with not a very significant change. Or another pre-PEC pocket, again, a year after radiotherapy, much of the landmarks are in place. Or this one, again, with acceptable results. And I believe the ADMs are the #1 reason behind these better results. So although autologous reconstruction is still the gold standard after radiotherapy, I believe this is as close as we can get using ADMs to support our implant-based reconstructions. And the implants, as I said, stay in place and somewhat soft. Of course, radiotherapy response is a very individual response, and we cannot say that pre-PEC works beautifully, sub-PEC works badly. This is an individualized response, but overall, our experience has been that getting the muscle out of the equation plays out well in a radiotherapy setting. So you see the muscle contraction with no animation deformity, which is a plus of the pre-peg technique. As is shown in this paper by Dr. Svitani, expander migration, whether be it expander or an implant, is less with irradiated pre-peg reconstruction. Also, the katkının rates are better in the long run. But these findings, as I said, are mostly with biologic substitutes. That's why we like them. We really don't have this data with the synthetic meshes. Actually, this is one of my patients irradiated with a tiger mesh, which is a long-term resorbable mesh. And you can see how stiff the fibrotic envelope is, not taking in fat and lost its elastic properties completely. So in my experience, the radiotherapy benefits, this is a pre-peg reconstruction too, but the radiotherapy benefits should be confined to biologics, at least for the time being. So the obvious benefits of the pre-peg plane challenge many of us to try to jump on this train. If we compare under muscle or above muscle techniques, and as I said, it matters a lot how big a portion of the muscle is used. So there's a lot of difference between total submuscular that we used historically and dual plane techniques. But if we look at the two groups roughly, muscle versus no muscle, pre-peg is usually technically easier. The recovery period is definitely quicker. Patients need much less analgesics. We don't use any narcotics anymore. The cleavage looks fuller because we can get the implant medialized when we don't have this medial muscle insertion. And it's easier to get a natural ptosis and a better match in unilateral cases. Animation deformity is a lot bigger issue in reconstruction than in augmentation. Many plastic surgeons use a dual plane in their augmentation cases, whereas we have mostly switched to pre-peg in recon cases. Because without muscle, there is no animation, and it affects a mastectomy pocket a lot more than a cosmetic augmentation. Return of sensation to the breast is a topic that several surgeons around the world I know are working on passionately. It's also been my personal experience that with pre-peg reconstruction, because the intercostal nerves in the lower lateral portion are not violated, as we do while raising the serratus fasciae in submuscular technique, the return of sensory innervation is better and much quicker. And this is important to note. This is one of our patients because during the dissection of a submuscular pocket laterally, recruiting the serratus fascia to close the lateral border of the implant, this nerve is severed even if it were preserved during the mastectomy. So it is us, the reconstructive surgeons, who are actually putting a blow on the sensory innervation. So this is the lateral side closure in this historical subpectoral technique, creating this nerve damage. So let's look at the patient selection criteria for a pre-peg reconstruction. Now this has been discussed in different papers and there are some controversial issues, but the patient pool has certainly been fast expanding. Today, not only those slim patients with rather small to medium-sized breasts qualify for this technique, but also bigger, more ptotic breasts can be reconstructed without using the muscle. And even higher BMI patients may qualify with meticulous patient selection. A major indication, came to the PMRT group, as I said, in those patients with anticipated radiotherapy. Pre-peg reconstruction has shifted from being a contraindication to being an actual indication for the reasons I've just mentioned regarding implant migration. So evaluation of flap perfusion after mastectomy is key in making the decision to go pre-peg. And even if we have all, well-perfused flaps with sufficient thickness, we try to do a pre-peg reconstruction in most patients nowadays. Even if we don't have great skin quality, like thin dermis, I ask the patients for stretch marks, poor camouflage, we switch to expanders and stage the reconstruction with fat grafting for the sake of still keeping to the pre-peg pocket and sparing the muscle. So this is a patient with left breast cancer. We also plan to do a risk-reducing mastectomy on the right side. ICG angiography has been a great tool to evaluate flap perfusion, especially in the early learning curve of pre-PEC DTI. We don't routinely do it now. But we first evaluate the perfusion once after the mastectomy is finished to be on the same page with our resection team before we begin our reconstruction. And this is to evaluate overall perfusion. At this step, we decide go on with immediate reconstruction or delay it altogether. We then do another evaluation after we insert the sizer in pre-PEC position, and this time we decide to whether insert a full volume implant or stage the reconstruction by inserting an expander at this stage. So ICG angiography is performed twice, once after the mastectomy and once after we fit in our final volume implant. So this was that case. Outcome at 3 weeks, the left nipple had to be resected due to tumor infiltration, but both sides look fairly symmetrical with pre-PEC implants. And there are many ways of going pre-PEC. Innovative names and techniques have come up basically to wrap it all around or just to cover the anterior surface. And there have been reports of higher incidence of seroma with the initial whole wrap techniques even leading to 27% reconstructive loss. This is another study comparing whole wrap with anterior cover, again stating higher seroma rates and reconstructive loss with full cover. But then again, the technology has evolved. Both material and the design have been revised. We have now more sophisticated products on the market, and they are surely very practical. Much of the work is done on the back table, even at the same time with mastectomy, especially in bilateral cases. When one side is done, I just jump in my sizer, and while the mastectomy team is doing the other breast, I prepare my wraps. Then I simply insert my reconstructed implant, again using sleeves to prevent contamination and shearing. The location or the length of the incision is not a problem since you don't bother with trying to put sutures inside. And then it's suggested that we put a couple more stitches stabilizing both the anterior surface to the skin and back on the chest wall to enhance incorporation and prevent seroma. This is a unilateral case with the porcine whole wrap pocket with reasonable ptosis even early on. Same thing here, different product. Although this is said to be a whole wrap, it is actually not. Much of the back is not covered. It's a thinner product and it's meshed, so it's supposed to be less seromogenic. Although I have only a few cases, I should say that I have seen seromas with this product as well. So none of the products on the market is exempt from seroma. And the cost with these pre-cut pockets are much higher, almost 3 times as high as the same product that comes as a sheet. So it should really justify the cost to pay that much of money to a pre-cut pocket. We compared on the same patient whole wrap with anterior cover only. We made our own whole wrap cover on one side, and it's very easy to tear the sutures when you tailor make them. So using a funnel while inserting gives more stability and safety. Again, stabilize the ADM. And on the contralateral side, we use this P1 method to anchor the ADM and pull it over the implant. This is the technique we routinely use for anterior coverage, and this is the result at 5 months. If you compare, you can note some upper edge visibility on the whole wrap side, the more expensive side, whereas in the cam-10 technique, the ADM is stretched over the implant and the upper pole transition is better camouflaged. So, expensive as they are, the whole wrap pockets may not necessarily provide a better result after all, giving us a limited chance to play with the upper pole transition. So what about the problems I've experienced with ADMs? Lack of long-term soft tissue support was a problem unique to biologic substitutes I've used. Malposition, ptosis, lateralization causing some fluid in the pocket. It's like a vicious cycle, and even implant flip affected the long-term results, needing revisions. This is a pre-PEC patient, beautiful result at 1 month, only to stretch the lower pole in 1 year with even the stretch marks. Again, a previous reduction patient undergone bilateral pre-PEC reconstruction, only to find herself back to her pre-reduction state with recurrent ptosis due to heavy implants and tissue stretch with anterior wrap of the implant in pre-PEC pocket. But the synthetics are much stronger. I already stated that I don't use non-resorbable ones, but the newer products which provide support up to more than a year do better than biologics in terms of preventing malposition in larger implants of more than 500 cc sizes. Again, one of the biggest issues with using ADMs, as I said, is seroma. We know that the biologics perform slightly worse than synthetics in that sense, and the new generation resorbable meshes apparently do better, although I have not yet had a comparable experience, but it's still more than 10% in my ADM practice. And it's a lot of work in the clinic. We also incorporated using a mobile ultrasound just to get rid of this fluid, trying to be more proactive, sampling, ruling out infection, and certainly ALCL for long-standing cases. Like in this case, who came with progressive seroma at 1 year, and the cause is often non-integrated ADM. It is more common with smokers and also with high BMI patients with decreased blood supply to a large fatty mastectomy pocket. And the cytology in these patients typically reveals foreign body reaction, which is what we see where there is non-integration of the ADM material. Another issue is that if you think of ADM as a way of texturization, and if it's not well integrated, causing chronic inflammation, this might as well be a trigger for ALCL, regardless of the type of the implant surface. I was surprised to see that in the profile registry, ADM was there in 7% of the cases of ALCL. So we don't know if this has been the cause, but we can certainly say that it has not been a protective barrier either. So what if we don't use ADMs at all? I believe this may be an option in selected cases, and we see great results with PU-coated implants when carefully chosen. However, because who would be eligible after evaluating mastectomy flap perfusion and thickness following resection. This is one such patient, very young, good skin quality. We decided to go pre-pack with polyurethane-coated implants. The triple antibiotic solution gets absorbed on the PU coating, and an implant of 300 cc's absorbs up to 20 milliliters of this triple antibiotic solution. And this is, I think it's another factor possibly preventing early biofilm formation. And these implants are known to prevent capsular contracture. This may be one of the reasons why the preventive effect. Lateral incision enables easy access for exact positioning with PU surface. It's not very easy to reposition once it's inside the pocket. Nylon funnels help, but once it's adjusted, then we are pretty much done. So it's a quick technique. Refreshing wound edges and closing on a dermal shelf, again, is important. And of course, it's much easier than sewing in the ADM. And as I said, in selected cases, it's a great practical choice. This patient is a recent one in whom I was forced not to use ADMs because she was allergic to any known antibiotic on the market. I wanted to keep the drains I wanted to pull out the drains as early as possible. So this is a good mastectomy pocket with almost ideal flap thickness. Again, we use the polyurethane-coated lightweight implants. The B-lights come in polyurethane-coated as well, coating as well. 2 years after one session of fat grafting, it looks almost as good as a cosmetic augmentation. In heavier patients, we know that the risk of seroma with using ADMs is higher. In this group, we also usually have naturally thicker flaps, so PU-coated implants are a great option in high BMI patients, minimizing the drain stay and reducing the risk of seroma. This is a lady where we use 60 cc PU-coated implants in a pre-pack position with minimal downtime and a natural result at 6 months. For unilateral cases, it's also a great match to get symmetrical result, especially after 6 months to a year when the PU coating starts to adhere and the implant settles more comfortably in the pre-pack pocket. This is a unilateral case of a huge phylloides tumor treated with nipple-sparing mastectomy, and we inserted a PU-coated implant in the pre-pack position, restoring symmetry at 6 months. Another patient with fairly large-sized breasts.
Could you?
Right side is to undergo, because in the first program I was given 50 minutes and I prepared for 50 minutes, but I will wrap up. We can redrape the skin over the sticky surface and by this way avoid extra incisions. So here you see the mastectomy is performed through a lateral incision, 480 cc implant is inserted, and the skin redrapes beautifully around it. This is the final result on the table and at 3 months with acceptable symmetry. PU implants can also be used in skin-reducing cases because they stick with their posterior surface on the chest wall. They eliminate the pressure on the skin flaps. This is one such patient. The neck gets naturally elevated, so we don't really have to put the nipple as high up as a 19 centimeter as we do with the mastopexies. This is a very conservative way of drawing, and we can move the whole skin over the implant and redrape it, and it sticks. This is the final result on the table, and at 6 months after radiotherapy on the right side, again, the PU implant in a pre-packed pocket can withstand the test of radiotherapy. But not all PU implants perform well in the setting of radiotherapy, like this patient with significant upper edge visibility. So what we do is we revise, we remove the implant, the upper edge is released. With fat grafting, we can get a somewhat better result, although not ideal. We can get a better result at hiding the upper edge transition. So I will skip those. I had a technical modification. I can talk about it later in a talk. So I will quickly wrap up. This is my current algorithm for choosing material and technique in my pre-pack reconstruction. If at the end of mastectomy the patient has well-vascularized thick flaps, I go for the simplest choice of technique with minimal foreign material, and I use the PU-coated implants. No ADMs, less costs, and great results. If the flaps are thin but the vascularity is good, I either stage with expanders, especially in adjuvant radiotherapy candidates, use ADM in this first session to create a plane, and fat graft in the second stage following radiotherapy. If radiotherapy is not considered, a thick ADM like Braxon, bilateral, gets skin-reducing mastectomy, and autologous dermal flap is used. Again, if radiotherapy is planned, I still incorporate ADM in the pocket and cover it with dermal flap. So one final word about the ALCL concerns. I know questions may come up about the PU implants. What's the current data? They are considered to be a part of the macro texture group. However, implant texture is a surface irregularity of the silicone shell through vulcanization. This is exactly the reason this PU foam appears to be part of the capsule after biointegration. Thus, polyurethane implants are mistakenly put into the group of macro-textured implants. But they're not smooth surface either, and they have been associated with BIALCL. Current incidence is 1 in 74,000. It's less than the average. Also, soaking the PU foam with antibiotics ensures prolonged antibacterial effect. So, I'm going back. We can now convert our patients to a pre-packed pocket. I will cut my lecture here, and maybe we can talk about this pocket conversion, because it really helps with restoring the patient's quality of life. And this pre-packed pocket has been really revolutionary in our practice. Thank you. I can.
Thank you. Maybe we can take the questions after the session. I would like to invite Dr. Murat Çalıkapan to talk about the implant selection.
Dear colleagues and dear teachers of chairman, it's first of all, I would like to thank the organizing committee for their kind invitation. And this is very hard to talk after the dear Burcu. I said Burcu because she is my classmate, and we proud of you, my teachers, like Professor Müslümanoğlu. Today I will tell you about the implant selection in breast reconstruction. which are now indispensable is breast surgery. So. Yeah, breast surgery changed and improved much after the PET Hallstatt opened for the us in latest 18th century, and the caused diversity and increased our complication because due to using the reconstruction modeling and heal the patient when removing too much tissue. It's it's the radical mastectomy. Get less out, get better, but what's left doesn't matter. It's modified radical mastectomy, and if we remove even less and adding the radiotherapy, the patient gets better. Leave a lump behind this breast conserving surgery, and is the now is the gold standard oncoplastic surgery. Let the patient recover without leaving any cancerous tissue behind. Moreover, if you remove a little or only the breast shape will definitely remain. And the approximately 10 years we do it the onco-aesthetic surgery and let there be oncoplastic surgery and get a beautiful breast remain. So this evaluation, this slide. It's this is a breast modified radical mastectomy and without oncoplastic surgery, breast conserving surgery, and this is the reduction maboplasty techniques with oncoplastic surgery. The basis of oncoplastic surgery is proper planning, possible treatments for the patients, for example, chemo and radiotherapy. It's very important. Tumor location and breast tumor size ratio, it's very important for the planning. Patient's immune and psychological state is important, and most importantly, the expectation, the patients should be determined very well. These patients are oncological patients, and cosmetic expectation of the patient can be increased by the doctor himself and the people around her. These patients always must be said this is a cancer surgery. And all breast measurement of the patient should be made and recorded. The patient's request is very important in planning. And I think this is very good mark. The surgery you think is best for your patients may be not the best surgery. This is very important, and the patient must be included in all stages of surgery selection. Oncoplastic surgery, but in which quadrant the tumor is located? Tumor breast size ratio, how? According to the density of the breast and the prevalence of the microcalcification. Patient-related risk factor is important: smoking, obesity, diabetes, previous surgery. It is decided according to surgeon experience and preference. How much remove? Breast tissue to be removed in order to obtain a clear surgical margin. If less than 20%, this name is level 1 and 2 volume displacement. If more than remove tissue 20%, more than 20%, level 3 volume replacement surgery are performed. Is volume replacing technique is like an implant-based technique. It is more suitable for small and medium-sized breast. If you must doing the body mass index high patients, it's additional intervention and are required to reduce the skin envelope in medium and large breasts. Bilateral reconstruction is suitable for the volume replacing techniques. Absence of the adequate abdominal tissue, you don't do it the on this removal this other technique, and the patient's augmentation request should be considered. Implant-based reconstruction, there is no definite contraindication. Today, neoadjuvant chemotherapy and radiotherapy is not contraindication. Implant-based reconstruction, according to autolog repairs, easier to apply, does not require additional incision. Mastectomy and reconstruction can be done for the same incision, and breast skin color doesn't not change, does not cause donor site scar and morbidity in the patient, both providing better symmetry and creating cosmetic satisfaction. For example, providing a well-formed intramammarian fold or breast protection. This enables us to achieve the quality of life goal. Implant-based reconstruction, according to autolog repair, this is the disadvantage. It is more expensive. If immediate reconstruction will not be performed, the procedure can be complete in at least 2 sessions. Although completely inert, the implant, but the implant is the forever body, may have later complications such as capsule contraction or seroma. So, this is, as in the majority of cases, the breast reconstruction using an implant-based approach, and the implant is characteristic to a large extent define the recreated breast size and form. And you see the implant types. Fixed volume is smooth surface or texture surface. It's this implant is filled with silicone gel. According to shape, round or anatomical. And changing volume implants, its valve system is integrated into the implants, tissue expanders, and tissue expanders with port system. This called is the Baker implants, and permanent implants filled with saline. You see the smooth implant is the left side, smooth surface implant, and the texture implant. And you see the round and anatomical implant. And you see the left Baker. You see the is in the port system. You see the Baker tissue expander with port system. The implant can be used permanently. The Baker implant can be used permanently in tissue expansion by retracting the port under the skin. After the inflation process is completed, and this one is tissue expanders with integrate port system tissue expanders. So there are many types of implants of market, so the surgeon may have difficulties when choosing implants. First of all, the chosen implant should be made individually, because the same implant can look very different in 2 different people. So this is the very individually situation. And secondly, tissue-based measurements and soft tissue coverage and the patient desires is principles of the implant selection. This is very important measurement, because the tissue-based measurement, the size, height, and the projection of the implant are guided by this breast measurement. You will see the one is breast base width, and the 2, nipple to inframammary fold distance, and 3, intermammary distance, and the 4, sternal notch to the nipple distance, and the 5, you can see the number 5, soft tissue pinch test area is the medial of the breast. And this measurement is very useful and very important for the implant selection. The breast width measured from the anterior axillary line to the beginning of the intramammary distance. Anterior axillary lines and begin and the inframammary lines to go to. This distance is determining the implant base and implant base width, so determining size of the implant. And 1 is the implant base width, and so determining the size of implant. And the nipple, number 2, the nipple to intramammarian fold distance measured under the maximum stretch, guides in determining the height, and this means projection of implant. And the 3, the intermammary distance impacts the volume of the implant. And the 4, sternal notch to the nipple distance impacts the height of the implant, and that show us how the chest fits overall anterior trunk. So, you see this is the normal position in the to nipple the inframammarian fold distance, and under the maximum stretch is 1. If the between these measurements is 50% difference, this means your skin and soft tissue coverage is lost, and show us is the you should be the this situation the high projection implant you should be doing. If this not the difference between the 15%, you should be the high projection implants. Soft tissue coverage is soft tissue thickness after mastectomy, and the degree of skin laxity are also important consideration in implant selection. Soft tissue thickness is determined by the soft tissue pinch test. I show you the other slide, and which is performed in the medial upper pole in breasts. Soft tissue pinch test, the general opinion in the over 2 centimeters is a thick tissue layer. If you have a thick soft tissue coverage, a less cohesive implant. If you thin soft tissue coverage, a more cohesive implant is suitable. This is the soft tissue pinch test. Now, the area is the 5 area in the previous slide, and the medial of the breast. And I think it's very important decided this one is the patient desire, because implant selection should be performed in consultation with the patient and the preoperative planning stage. Ideally, a compromise between the patient's desire and the patient anatomical dimension should be reached. The surgeon's role is to counsel the patients on the optimal option, but ultimately the patient's desires need to be respected. It is used the 3D software programs that makes implant selection. It's very objective. 3D, this one is the 3D vector device. This is the 3D picture of the patients is taken with the multi-camera system. It can show how far the breast is separate from the midline, show breast base measurement. Post-op results can be defined to be patients. Here you see the vector system, and the patient enter around a cabin equipped with high-resolution camera. Many images are taken and processed with vector software. Thus, a 3-dimensional hologram of the patient is made. The Professor Özden show us the previously presentation in her case in the vector system, and you can see the automated measurements and to select breast implants, this system, and compare multiple scenarios. You can determine breast contours. The most important is, maybe is the most important, you can visualize the patient's expectations. And vector software is very important. Disadvantage is very expensive. Actually, saying the new is not extremely true, because the prepectoral implant has been popular again, and it has relatively easier to reach the acellular dermal matrix, and leading to the frequent use of these materials in breast reconstruction. The professors then say, and very detailed talking about the acellular dermal matrix. And what's the new in the implants type? is Belite implants is very important because it's product with inside the small air bubbles and 30 and 35% lighter with the normal implant. And the implants with microchip for safety purposes is new on the implant technology. Oh, it's my last and one slide. It's very important entity is breast implant associated anaplastic large cell lymphoma. You know, it is not a breast cancer. It's a type of immune system cancer. And first case defined in the 1997, and the World Health Organization classifies it as a separate disease in 2016. I searched the web and the other document, and this is the, I think, very current data. As of March 1 is 2023. The last data, 1,355 cases in the whole world, worldwide, and 52 deaths is caused about the BIA ALCL. This is so rare now, but we have using so many implants, I think the problem of future. And symptoms is presence of redness, swelling, and asymmetry in the implanted breast. The diagnosis is made by pathological examination of the fluid around the capsule. I'm using my personal practice until the 20 years in using the breast ultrasonography, and is the ultrasonography using its very easier diagnosis, this one, because you see the around silicone fluids, it's and take a sample is very easier. It's currently it's not possible to test for who is at risk of disease, which patient, which implant. It's there is not possible to test in here. And the treatment, it's remove the implant with capsule. Always capsulectomy is added to this operation. If there is no disseminated disease, not needed chemo or radiotherapy. Thanks for everything and for listening. Thank you.
Thank you very much, Murat. Could you come up to stage, Burcu? We will have our questions and answers, please. Yeah, the panel is now open for discussion. Any question or comment? Yes, Levent.
Sure. I want to ask to Burcu, Dr. Burcu, excellent presentation again. What do you think about the skin reducing mastectomies? Do you use any ADM, or do you, what kind of push you are using? It is prepectoral or underpectoral?
It also depends on the skin vascularity and skin thickness, flap thickness. Oftentimes I try to stay pre-pec in these patients as well. There's a lot of abundant skin, and I use the lower pole dermis to cover the lower pole of the implant, and I top it off with a piece of ADM to cover the upper border. Nowadays, these patients are high BMI patients, and if I can get away with using a polyurethane implant, I try to refrain from ADMs, using ADMs, because we see a lot of seroma issues in these patients.
In implant-based reconstruction, we are not very much happy with the radiation. So in long run, there is really big changes, and the capsule contracture increase very much, 5 years later more. So in general, what would you advise if the patient will take radiation therapy? So can we force the breast reconstruction breast conserving surgery, later on reconstruction, or firstly we don't care about it with radiation therapy? What do you say?
We can preserve the breast. Breast conserving surgery is a great way to start. If the breast can be conserved, I think it's the best overall outcome, even if it's irradiated. You know, when comparing with an implant, even if it's not irradiated. So if we can preserve the breast tissue, even in multicentric tumors, there are now great data accumulating that we can go ahead and preserve the breast in some selected cases with extreme oncoplasty techniques. And if it can be done, of course, I'm not a big fan who would say go ahead and do an implant reconstruction for patients. But of course, as a plastic surgeon, we can do flaps, and the gold standard is still flaps after radiotherapy, and at some point patients can be converted to a flap reconstruction if the implant does poorly over time.
So I'm doing a lot of reconstruction, implant-based reconstruction, but nowadays I like to postpone implant-based reconstruction who will get a radiation therapy force, even though the cosmetic outcome is not good. I like to force breast conserving surgery. Later on we delay to implant. Yes, please.
Yeah, so this is a really interesting question. So every one of us really showed this very nice picture of the little devil. We don't like radiation, so for that reason we are intensively discussing in Germany to put radiation in a neoadjuvant manner. So it took a lot of time to design the study protocol. And we thought starting with the trial 2 years ago, but now I think we will start within the running year, so maybe in quartile number 3. And besides effects on tumor and tumor response, I hope that we get better results in implant reconstruction. So I'm with you. So every one of us is every patient is recommended to have an autologous reconstruction if radiation is planned or radiation was done. But of course, more than 80% of the patients, they stay with their implants, so they want to have an implant reconstruction. Maybe we can improve outcome in putting the radiation in a neoadjuvant setting.
First you will give the radiation, then implant-based reconstruction, or we have a experience 20 cases. But if you don't wait too long time for the reconstruction, infection rate and there is really very high. So we lost a lot of implants.
Yeah. Prada is a different. So I will put my editor's hat here. I just wanted to point out 2 things that are from the literature and do not necessarily reflect my opinion. But so we know that implants and radiotherapy are not best friends. The best available evidence nowadays is a network meta-analysis published in the EJSO last year. It is exactly as you said, the best outcomes are by autologous reconstruction. There is no doubt about that. And if you are to do implant, the results of this meta-analysis suggested that you should go directly with an implant and preferably prepectoral, because the contraction rates are 1/4 of what is with the retropectoral. So the idea of having some people that used to put an expander and expand the muscle and deflate the that's probably not the way to go. Apart from the Prada, that did have a different radiotherapy protocol, there is also a bi-institutional retrospective report on the exact policy, so reversing the sequence of treatments from France. And what they saw is that the best way to deal with the complications after neoadjuvant chemotherapy, radiotherapy, and implant-based reconstruction would be ideally to go to surgery the next day after the last radiotherapy before the fibrosis effect starts to kick in, which normally would take some 6 weeks. Okay.
before the radiotherapy fibrosis settles. I think that's the best way to go. As for the expanders, I think the two-stage reconstruction has also been revised. We are revising our expander use, the timing of expander expansion without deflation, and we still go on to put our expanders in the pre-pack pocket. We don't have anything else to expand anymore. We don't have to expand the muscle, and the new technology expanders with soft shell covers with the compatible MRI compatible ports, integrated ports, do very well with expander exposure rates were high historically. Now with this new technology and with the new revised technique, I think the two-stage has to be revisited because it gives us a way to...
The two-stage, we could all... What I do in this case is that will not get autologous reconstruction because they don't want to, is that I do what Gian Farhadi does, which is a prepectoral expander that will stay in place. Babysitter, change to implant, and the third stage will be lipofilling if needed in these cases.
Yes, this is what I do. I have started currently doing this because with the new adjuvant patients coming over, we really don't have time dealing with the wound healing issues, and expander gives us a way to play with the...
And the best thing is that the capsule is your ADM. This
new soft tissue expanders, I don't use ADMs in the pre-pack pocket. I just stitch it and it works.
Okay, yes. Thank you very much for your presentation. I have a comment and question to you. And I think fat grafting is not recommendable after implant reconstruction because fat may cause microcalcifications and misunderstanding of DCIS recurrence, maybe 30% is really high. This is one. Maybe non-tumor bearing breast can be used. I don't know. This is my opinion.
Non-tumor even the breast conserving surgery has been justified in terms of fat grafting because with the newer fat grafting injection techniques, we don't put a lot of fat deposit in a certain location, and it vascularizes very well. We have revised the technique, and we put it in stages. We don't overload the mastectomy flaps, and it really rejuvenates the skin after the radiotherapy effects have settled. So it has been justified oncologically, even in those patients with who have undergone breast conserving surgery after a certain period of time, except the certain red flags. Of course, we do get away from those, and the radiologists are also accustomed to evaluating those fat cysts and making them clear that it's not a recurrence.
And if capsular contracture happened after pre-pack reconstruction and radiotherapy, what is your strategy?
Yeah, I just go in one more time. And she opts for a DTI because in these patients I tell them my current algorithm is to do a two-stage because the second stage gives me another option to another chance to play with this type of capsular modifications as well as fat grafting. But some patients insist on having a DTI, and if they are qualified for a DTI, I go for a DTI, but telling them that we have to leave a window open for revisions, because when you promise the patient a DTI reconstruction and then you want to in one more time after radiotherapy, this is called a revision, and you don't get any reimbursements. The insurance companies as well, it's very hard for the patient to accept to have another surgery. It's a two-stage. You have to go into exchange or implant. As I get more senior, I know better to say right away. But in those patients who don't want a two-stage, I tell them that 90% of the patients will go on to get a revision if they want to perfect their results after.
Any question?
I don't like. I'm not. Yeah, I'm not very. I think I'm not doing a good job with the Beckers. I have never, because they don't behave like expanders, they don't behave like permanent implants. At some point, I exchanged them to definitive implants.
Seroma is another problem, real problem. How many? 12%. And the loss,
of work.
implant loss. What is your
no?
implant?
Hopefully no, but I really jump on the case proactively. I have this ultrasound and I drain them and I put them on antibiotics. I immobilize and I try to see the culprit, what's causing this seroma. It's usually the non-integration problem, and oftentimes I have to go back in and debride the non-integrated part of the ADMs that I've used. So now I refrain from using big pieces of ADM in obese patients with fatty, poorly vascularized mastectomy flaps. And the excess mobility of the implant also is a cause for implant, for fluid around the implant. And those mesmo and nanotexture surfaces who are very much promoted for preventing ALCL are the main cause of these seromas, because the more the implant moves inside the pocket, the more seroma you get.
In those circumstances, patience and surgeon's patience together is necessary to solve the problem. It takes long time.
One magic recipe for all patients. I think technically everything is easy. I think it's the patient selection that matters, that gives out the experience.
Thank you very much. No question. Okay, we have a coffee break. Thank you.
But let me introduce them, beginning with our international colleagues. Andreas Karakatsanis from Zurich, Uppsala University, Department of Surgical Sciences, Associate Professor of Surgery. Ash Kotari from United Kingdom, Gates and St. Thomas NHS Foundation Trust. He's a senior lecturer at King's College and also the clinical head on the chair of breast tumor board. And Mark Thiel, he's from Germany, the director of Department of Gynecologic Oncology in Frankfurt. And our national delegates, Görkem Aksu from Kocaeli Üniversitesi, the Department of Radiation Oncology, Professor of Radiation Oncology, Dr. Devrim Çabuk, also from Kocaeli University, Department of Medical Oncology, he's the Professor of Medical Oncology, Erkin Arıbal, Acıbadem University, Department of Radiology, and Handan Kaya, Marmara University, Department of Pathology. We have very detailed cases here. We have one detailed case and other 4 hot shots in breast cancer management. So we have some time and shortage. So I would like to begin, if you let me.
Can they see the screen? Because we are blocking the screen.
Yes, they can see it.
Or should we go there?
It's okay. I think they decided like this. The designers decided like this. So our first case is a 50-year-old woman. She is asymptomatic and during a routine annual physical examination, her surgeon discovered a lump in her right breast and an palpable and movable axillary lymph node. She has no other history of breast cancer risk factors. Okay. And her clinical exam also revealed an upper outer quadrant right breast mass with a palpable movable axillary right lymph node. Her echo status is 0. Her metabolic and the blood count revealed nothing significant. So, Professor Arbal, I would like to ask you about her mammography. Could you please give us some idea about the lesion?
It's a fatty mammogram. Thank you. It's a fatty mammogram, and we can see on the axillary tail a large mass of more than 3 centimeters, I guess. It looks malignant.
Okay, thank you. And we proceed her sonographic view and also the axillary lymph node sonography, real-time sonographic image. Could you please?
Yeah, it's 26 millimeters. It's quite big, and we can see the lymph node on the your right-hand side, and the lymph node has a asymmetrical cortical hypertrophia and the vasculature, which shows that it's an axillary metastasis as well. So it looks like a T2 and 1 tumor, radiologically.
Okay, we move on. And at this point, I'd like to ask you, what are your indications for breast MRI? Because we use breast MRI so regularly. And also, would you like some kind of MRI for this patient, or would you proceed with the biopsy?
I would proceed with the biopsy. I would not ask for MRI because I told at the beginning that it's a fatty breast, so we can see everything. So
okay,
we don't
great.
need an additional MRI imaging.
Yes, agreed. But she also had an MRI showing 3 centimeter mass, as you mentioned, and a linear enhancement. So your decision is still the same, I guess?
Yeah, same. Yeah.
Okay. So, Professor, Andreas, what would be your next step for this patient?
So, we have not completed triple diagnostic, so we need to biopsy, and optimally we would like to obtain core biopsy from the tumor and optimally from the suspicious lymph node.
Great. It has been done, and it showed that an invasive ductal carcinoma, grade 2, ER weakly positive, PR negative, and HER2 2 positive. So at this point, I would like to ask Professor Kaya, is this pathology report, this one, is adequate for you, or what other information should be included on our breast core biopsy pathology report from your side?
Firstly, Ki67 is missing. Secondly, HER2 needs confirmation by in situ hybridization, either by fluorescein or Kish or Sish needs confirmation.
Okay, thank you. And I'd like the oncologic point of view. What is the importance of Ki-67 in your side?
In this patient, first we want to learn the results of SISH. If it's HER2 positive, so it's not so important for us,
If negative?
Ki-67. But if there is luminal tumors, we want to know the Ki-67. For the aggressive tumors, if the Ki-67 is high, we can decide to give chemotherapy, neoadjuvant chemotherapy.
Yes, great, thank you. And her FISH results, HER2 CEP ratio is more than 2, and the HER2 copy number signals over cells is more than 4.
It's certainly amplified, HER2 amplification.
So this is FISH positive or?
It's positive.
Positive,
right.
yes. And also we know that there are some differences between the labs regarding FISH status. What are the reasons for these differences?
Probably some pitfalls related with tissue processing. It could be, or it could be related with intratumoral heterogeneity. At this level, if we are speaking about a true cut biopsy, then it is probably related with the tissue processing, because there are small amount of tumor there. I wouldn't expect to get intratumoral heterogeneity in the true cut biopsy.
Thank you. So when we proceed, I would like to ask Ash, how about the axillary evaluation? Is the imaging enough, or you would recommend palpation-guided FNA, US-guided FNA, or the core biopsy?
I would recommend US-guided core biopsy.
Core biopsy. Why core biopsy? Why not FNA?
So it depends on what you're doing the core biopsy for. If you want information that will change your management in terms of heterogeneity and difference of receptors between the primary and the metastasis in the node, then you would do a core biopsy. You can also do a nice FNA and do a cell block if you're that good. But if you only want to know that the node is positive or negative, an FNA will do.
Yes, great. Or
higher, of course, 74% of sensitivity with FNAC versus 84% or 87% with core.
Sure, but would it be enough for some tumor types? I mean, if the tumor is triple negative, for example, do you like to have FNA or core? Because usually we do FNA, as you know, but if the tumor is triple negative, your axillary.
So the thing,
yes,
we had this discussion just last week, remember? So if we had landed in the case of a patient that had a marginally amplified but FISH negative HER2 result, we know that there is a 5 to 7% discordance to that, and this is where the core from the node would probably tell you if you really have a HER2 disease, and in this case that would be clinically relevant because it would affect treatment plans, of course.
Yes. Any other idea about it, Professor Thiel?
No, the same. And we had this apparated progesterone receptor, and I mean, if they are because of the heterogeneity in the tumor tissue, so maybe you had a hormone receptor positive case and not an aberrant receptor, so this could be an influence on the triple negative as a diagnosis.
But in this case, you have a HER2 positive primary, so your node is not going to give you more information.
Yes, but I revised the question for a case with triple negative breast cancer or the low HER2, so you answered that. Okay, thank you. Professor Müslümanoğlu, please, we can have all of your questions at the end if possible, because we have. Yes. Yes.
No, he didn't say routinely.
We do not do it routinely, but if you have a patient that you marginally classify as triple negative because they are not amplified on SISH, the phenomenon of tumor heterogeneity in the primary tumor is much higher than that of the axillary metastasis. So if you get a patient like that that is truly HER2 positive just on chemotherapy, and you will probably be giving them pembrolizumab without any reason. That's why you need to know before starting administering medication.
But you should be giving them Herceptin.
Yeah.
So ultrasound-guided axillary FNA has been performed, and it has been confirmed to be the malignant as well. And after that, what would you order for staging in your countries? Is there any difference for this patient clinically stage 2B? Andreas, yeah, please.
So there is significant debate with regards to whether you need to stage all these patients. By tradition, we stage by PET-CT, but this has to do mostly not with us hunting the metastases, but because the medical oncologists find it a more satisfying modality for them to assess response, especially in the case of luminal B cancers. So I would go for a PET-CT. With regards to the brain MRI, the only case of asymptomatic patients that we would screen for brain metastasis is the case of triple-negative breast cancer, because there is a higher percentage of clinically occult asymptomatic disease in this case.
Do you have another idea?
Just CT scan, bone scan, and no brain MRI in the asymptomatic patients. So this is data that comes from our big registry. So this is maybe the difference, and PET-CT is too costly.
In your country, yeah. What's your...
And if you have a medial tumor, then the radiation oncologists will prefer a PET-CT because they want to look for IMC loads.
Okay. And in Turkey,
Not
our medical oncologists...
Not all medical oncologists. It's stage 2. We usually want to see PET-CT in stage 3 patients maybe, but in some aggressive tumors like triple negative or HER2 positive, maybe we can perform it in stage 2. But according to me, it's okay, CT and bone scan is enough also.
Okay, regarding the recommendations
and also
of the
we
guidelines.
don't, for response, we don't need PET-CT, I think.
Yes, your idea, sure.
Maybe if there is bulky lymph nodes in axilla, and as doctor mentioned that it's a medial tumor, there will be an increasing risk of internal mammalian lymph node positivity. So in this case, we can maybe add PET-CT to irradiate the internal mammalians in medial tumors and bulky lymph nodes in the axilla.
In a selected group of patients, yes.
Yes,
sure.
in selected patients.
Yep.
And also we order brain MRI for only symptomatic patients.
Yes. Okay, that's great. Yeah. So you're in the multidisciplinary meeting to discuss this patient. I'd like to ask our surgeons. What would you recommend? D. Okay, we can proceed. Any objection? No. Okay.
No.
Then we proceed.
Very clear D.
But if the patient, if your was luminal B with a limited axillary disease, or a metaplastic or a lobular histology that has not good response to systemic chemo, would you change your mind of any kind? Yes, please.
Yes, of course. So if we stay for triple negative disease, we know the heterogeneity. Metaplastic has to go to the OR first because we don't have response to chemotherapy. If we have an apocrine morphology, for example, we don't go for an adjuvant treatment as well. So therefore, it depends on what type of triple negative disease do we have. In HER2 positive disease, of course, we go for neoadjuvant chemotherapy. The limit is 5 millimeter. Below 5 millimeter, this is debatable. But then in combination with the 2 antibodies, I know this is the APT study going there. There we have data, but I think HER2 positive is an aggressive tumor type, so we go for neoadjuvant. And in luminal B, of course, well, in luminal B is different. We would go for a window of opportunity of an endocrine induction treatment of 4 weeks to measure Ki-67 first and later on, and then we make our decisions, we go for neoadjuvant chemotherapy or not. So this is really different and more complicated.
I'll give you the word, but first, can we get the ideas from our faculty? Yes, Andreas, please.
With regards to metaplastic cancers, apocrine, or all these triple negatives that either do not require preoperative treatment or will not respond to preoperative treatment, I think that this is a very reasonable thing to discuss. With regards to lobular or luminal B, non-specific type, I think that the notion here is that if the patient will need chemotherapy anyway,
adjuvantly, yeah,
you might as well give it up front. What changes is the need and perhaps the modality to monitor response. For example, if we are dealing with the luminal B that is a luminal B like a 35% Ki67, but not the aggressive ones, where you know that the Ki67 will probably, the higher it is, the better the response to neoadjuvant chemotherapy. Our oncologists have concerns about non-response and progression, and this is where they value the role of PET, actually.
So in fact, I want to ask the medical oncologist. So do you think that when you know the tumor is not going to be that responsive to chemotherapy, by giving chemotherapy in the adjuvant setting, you can actually de-escalate the chemotherapy as opposed to neoadjuvant?
Yes. Yeah. I want to ask, is this patient premenopausal or postmenopausal? Yeah, it depends, because if there is limited axillary disease, maybe she would not need adjuvant chemotherapy.
Yes, sure.
If we can especially perform genomic profiling, so 1 to 3 lymph node positive patients may not receive adjuvant chemotherapy.
Yes.
So in these patients, we usually don't offer neoadjuvant therapy. But if it's changed, if the patient is premenopausal.
We are not talking anymore about a real luminal B, do we?
Yes.
Then if you have a gene signature that says low risk, then you're not really interested in distinguishing luminal A or luminal B like.
Yeah.
You have a low risk.
But this is the point I wanted to say. So
Yes.
if we want to differ in luminal B who is the patient for chemotherapy, then we need more information. If we have limited axillary disease, that means 1 up to 3 lymph nodes.
Yes, 1 up to 3 lymph nodes.
We have good data from the RxPonder trial.
Yes.
And we have good data from the ADAPT trial and the interim analysis of the ADAPT cycle trial, so that we need an endocrine treatment to get an idea. So who will respond to an endocrine treatment? So this is really different. But my question was, luminal B and HER2 positive is still HER2 positive and not
Yes.
luminal B. So this was not the question.
Yeah.
All right.
That was not. Okay. So for this, the presented patient, MDM decision was the neoadjuvant systemic therapy. And what about the markings? We have been discussing it till the morning. The tumor and the axilla, and if more than 1 pathologic node, how many nodes? Andreas, for example, you do sample and mark.
1 marker in the tumor, 1 marker in the axilla, either in the single node or in the most prominent node.
And your marking period time at the same sampling procedure before you confirm the metastasis,
So
or after?
Our strategy is early MAG-seed implantation, and for that you need pathological confirmation. So we would, as soon as we knew that this is metastatic, and you are medico-legally allowed to put a marker that you will retrieve, we will put the MAG-seed in the beginning of neoadjuvant chemotherapy, breast and axilla.
Any objection or difference?
Well,
Your clinical practice?
We don't put MAG seed or the final seed at the same initially, so we would put just a clip in the lymph node and the tumor, and then MAG seed whenever we come to surgery, because our oncologists don't like that even little bloom in the axilla, because they want to look at the axilla in more clarity.
And Mark, your clinical practice?
Yeah, I think it depends on the healthcare system and then the reimbursement. So we try to just make the biopsy, and then if we have a positive lymph node, patient has to come back. But if we have a real clear metastasis, then we put the MAG-seed directly in. So it's something in between.
Yeah. But the most accurate is if you mark it at the same time.
Yes. So for this patient, for example, would you recommend genetic testing? And when do you usually recommend genetic testing? And also, which panel would you like? And also, I would like to learn how long does it take to get results in your countries? She's a postmenopausal 50 years old woman.
With the HER2 positive cancer.
HER2 positive
and
cancer.
no family history initially.
No family history.
There's no strong indication for genetic panel testing. But if you wanted to do a genetic panel, you can do a panel testing as opposed to whole genome sequencing, which is cheaper. We do 8 genes. It takes, if you do the P53, it takes 6 weeks. But if you don't do the P53, then it takes 3 weeks to come back. So we would do it at diagnosis.
Yeah, it's not a strong indication to recommend a genetic testing because of the positive disease, so it's less than 5% risk that this is genetic determinated, the tumor. But if we test, then of course we would go for a panel, and we have a German panel consists of 25 genes. So this is what we would recommend. It takes 6 weeks, but it depends where you test. So do you go to a genetic colleague, or do you go to university, or do you go to another lab? So it's 6 weeks up to 2.5 months, but this is the time we need. Not in this case, but if we talk about companion diagnostic for, let's say, a triple negative disease that has had a non-PAT CR and you want to have a laparib, for example, indicated, then of course we go for, we should go for a panel, but then we just go for the BRCA 1 or 2.
Okay, and you?
So we've actually in the UK now introduced what we call mainstreaming. So there's certain indications like triple negative under the age of 60, male breast cancers, or very strong history of ovarian cancer under the age of 40, or triple positive under the age of 30, then we would do mainstream. So when we see them in clinic, we counsel them for genetic testing, not send them to the genetics department. But if there's borderline, then I think as the students, there is a very good tool to use online. It's called CanRisk. So it's a very, very information exhaustive tool. We have to input a lot of stuff, but it gives you very accurate feedback of whether this patient needs genetic testing or not. So you don't have to rely on experts. It's there, software, AI does it for you.
So Andreas, in Switzerland, what is your indication for genetic testing?
So in Sweden, there are
Sweden.
There are
I'm sorry.
two different pathways to do that. And the one is where you have low or moderate suspicion, and that may be performed in a manner that will not affect your planning, but it will be done by the end of neoadjuvant therapy so that you can plan surgery. And then we have the 040, 150, 260 rule, which is a patient with no relatives under the age of 40, a patient with one relative, but the patient being between 40 and 50, and the patient between 50 and 60, but with two relatives. Any history of ovarian cancer, any history of pancreatic adenocarcinoma and aggressive prostata cancer, male breast cancer, triple negative breast cancer regardless of age, triple positive over 30. Yeah, it's a long exhaustive list.
Manchester score, CanRisk.
Yes.
Don't remember all this. You don't.
The question is, do you order genetic testing, or you consult a geneticist before ordering a genetic test?
In the case of mainstreaming, in the way that we implement it, there is a template available on the online system. You fill it, the patient leaves blood the same day, and you get results in 2 weeks.
2 weeks.
Yeah.
All the testing is done by genetics. The consent is done by the surgeons. But where there's these borderline cases where this one certainly would be very low, but let's say she had a family history and you wanted to refer, then we have to refer her to genetics, but we also do it with the Manchester score. So the Manchester score is high enough, we know she's going to have it, so we counsel her accordingly.
Okay. So great. Let's move on.
The CanRisk, by the way, is the formerly known as Boadicea for you that may not be. It is the Cambridge University.
Okay. So do you perform any kind of patient education for the lymphedema, before the initiation of your any treatment? Because all of these ladies have some kind of lymphedema risk, and they should be educated before the initiation of any treatment. Do you have some kind of programs in your
all patients in the unit will undergo a baseline surgical assessment, where we will record the baseline surgical intention, which is what do you need to do based on guidelines if she were operated tomorrow, upfront that is. Out of that, they are being informed on risks for shoulder arm morbidity, lymphedema, constriction of movement, chest wall morbidity, and so on. We identify potential solutions. It may that be breast conserving surgery or mastectomy with or without reconstruction, and they review a photo bank. This is part of the standard consultation.
So we do slightly differently. We do an LDEX score, so we do a volumetric measurement of the affected limb and the opposite limb. But we don't give them all the information about the risk of lymphedema, especially because if it's surgically based, or the pathophysiology of the lymphedema is surgery. Because there's so much information you're giving them up front. Then they go to the oncology and they scare the pants off them, saying you're going to have all these little problems. So for them to actually remember all this becomes a bit of an issue, because you're throwing too much information. There's clinical trials, there's chemotherapy, you're going to have radiotherapy, genetic testing. A patient cannot retain that kind of information. So we get the baseline photography, we get the measurements, and then we counsel them for the surgery. When it comes to surgery, about what kind of surgery they need, the risk is then told to them in that way. But the other interesting part is, do the oncologists tell them that there is a risk of chemotherapy-induced lymphedema? It's not the surgeon's fault only.
So, ask the medical oncologist, Professor Çabuk, do you give any kind of information regarding lymphedema for your patients who will going to have some kind of systemic
That's all,
therapy?
especially platinums.
Lymphedema?
Yeah, lymphedema.
After surgery, yes, we give information, and how can use their arm. We give information about lymphedema after surgery,
okay,
not before chemotherapy.
Thank you. Yeah.
So if you look at the risks
in Germany,
for lymphedema,
yes, I got it.
Neoadjuvant chemotherapy is actually a risk
Yes.
of postoperative lymphedema.
Yes. We mean that if a patient has neoadjuvant chemotherapy, her lymphedema risk after the surgery is higher than the upfront surgery. So this should be also mentioned while we are discussing the neoadjuvant systemic therapy with the patient. But usually in Turkey, the surgeons do that.
Okay.
We do it.
But
Okay.
also it depends on the surgery. If you do only sentinel lymph node biopsy, the risk is lower.
No, the risk
Axillary dissection.
across, if you use platinums, anything you do to the axilla, the risk is higher.
So we should give information.
But your surgeons are
Read it. So in Germany, is there anything different regarding this?
Yes, so we should counsel the patients regarding lymphedema. We talk to them, but we don't do a volumetric measurement. So there was a really good study presented. I don't remember, San Antonio, ASCO last year, the year before.
Yes.
And we came back and said, so this is so important, we have to do that. And then we talked to the clinical management, and they said, well, we don't have money, so you can measure. So we measure in the patients who are at risk, but who is at risk. So therefore, this is not very well solved the problem.
Okay, thank you. And then let's come to the radiation oncology point of view. Görkem, would it be possible to radiate a breast without reduction mammoplasty, for example, a 100D or larger? Or what are the issues about breast size and degree of ptosis relevant to radiotherapy?
The breast size is a major problem to give radiotherapy, and it's ideal to not only they use the 100D, 19D, but the breast position under the simulation is also very important. And the degree of ptosis is also important. So the ideal thing is to see these breasts before surgery. So if we can radiate them, and even if it's ideal to simulate them, because whatever the lung doses or the heart doses, the breast is left-sided or right-sided. These are all important things. Will you radiate internal mammalian lymph nodes? This is also an item. But generally, till 100D, I don't know the size of this patients, but I think it's smaller than 100D. I think
Nearly 100.
Nearly 100.
Yeah.
It's near a border, but the volume also is important. What's the volume of the breast? What's the degree of the breast when it lies to the simulation room? So it's ideal to see patients with big breasts before the surgery or neoadjuvant chemotherapy to go with the reduction mammoplasty, but we can't argue it how many we will see before surgery.
So all of the patients should be, of course, consulted radiation oncology just before just deciding to perform some kind of reduction or not. So the decision has been made regarding neoadjuvant therapy, and I would like to turn to Professor Çabuk. What would you recommend as an initial chemo regimen for this patient?
We can start with anthracycline-based regimen and then taxane and dual anti-HER2 therapy. But you can also start with taxane and anti-HER2 therapy and then anthracycline.
So you prefer dual agent blockage
Dual,
regarding
yes.
HER2?
Yes.
Yep. Okay.
Trastuzumab and pertuzumab.
Sure. So how would you revise your recommendation if the tumor was ER negative, PR positive, or vice versa? Would it change your mind?
No, it will not change. This patient is HER2 positive. If hormone receptor positive, the PCR rates are less than the other hormone receptor negative patients, but it will not change our regimen.
Okay. I would like to learn your follow-up intervals in your countries for a patient that getting neoadjuvant treatment. Within which periods do you have some kind of physical examination? Do you see your patients during neoadjuvant systemic therapy periods, or the medical oncologists do that?
So we do our monitoring ourselves because as gynecologists we are trained in ultrasound, so this was a tumor that was visible in ultrasound, and all the patients are seen every 2 cycles. That means when we start with EC, I mean, we could go for an anthracycline-free regimen, but if you go for a neoadjuvant, then I don't want to de-escalate in the beginning and then escalate in a post-neoadjuvant setting, so therefore start properly, and for that reason we would go for EC or AC, and then after the first 2 cycles we would do a monitoring. And this is regarding the tumor size, and then of course we do have monitorings regarding blood samples and all the lab measurements and so on. But this is, I don't think that you mean that. And of course for cardiotoxicity and all that stuff that we regularly do when we perform a HER2-directed treatment.
Any other different clinical practice?
So. If you ask me, I think that when it comes to that, the Germans do it best, because this is the most relevant way, especially to this particular patient. What we usually do is that, especially in the case where surgical de-escalation is one of the initial intentions, we want to take a look at them every other cycle, like Mark described, and we will do an ultrasound for them. In general, the disease does not need to be monitored with a specific modality. The principle is that you stick to the modality that made you make the plan from the beginning. So if you felt confident with a mammogram and an ultrasound, you proceed with that. If you felt confident, or if you did an MRI for any reason and that changed your plan, then you should monitor by MRI, and so on. Literature-wise, MRI and PET after the second treatment have shown to have the highest accuracy in order to predict path CR, but neither the one nor the other correlate to final tumor size better than the ultrasound, as the Dutch Inspire trial showed.
Okay, do you use MRI for each patient before neoadjuvant systemic therapy? No, no,
So
no. You? Yeah, Ash?
We are guilty of using MRI scans, and that's purely because our oncologists do not see the patients in between. So unlike Germany and in Sweden, we've got oncologists who take the patients. So we don't see them for 4 months, and then they come back to us with progressive disease sometimes, which has not been picked up. So, and 3 to 4% of patients will progress on chemotherapy, regardless of how good your chemotherapy is. So these patients are not being seen in the UK, and we are getting them, everyone gets an MRI scan. So they do a cycle 2 ultrasound scan and MRI scan. I don't know whether anyone looks at the report, but someone is supposed to look at the report. And then at the end, they'll have it, and then it comes to the MDM to say, now what kind of surgery do you want to do? So where we are poor in other resources, we spend a lot of money on these things.
Yes, sure. And your point of view, Professor Erbal, regarding radiology. If the patient's going to have some kind of neoadjuvant systemic therapy, what do you think the most accurate radiologic method of seeing, revealing the radiologic response, the accuracy of the diagnostics?
It's MRI, but in this case we didn't have MRI because her breast was fatty. So if you don't need the MRI at the first stage, at the beginning, then you don't do MRI anymore. But if you do MRI at the first, then you should go with MRI, particularly for younger patients, because the neoadjuvant cases are mostly younger patients with dense breasts. So we do MRI, and we do MRI at the end. Our oncologists do not ask during the treatment. They don't ask any radiological imaging. But after the second cycle is the recommended time to do it if you want to. And what else? And we have contrast-enhanced mammogram. Not all patients can go under MRI, so in some patients we do contrast-enhanced mammogram. Then we do continue with the contrast-enhanced mammogram.
Okay, thank you. And you? Yes,
Yes, too
please.
much about medical oncologists. We see the patient every cycle and do physical examination every 2 to 3 cycles. And if we have clinical response, so we don't need radiologic imaging. But at the end of neoadjuvant treatment, yes, we order. But during the neoadjuvant treatment, we follow patients' physical examination.
I just said what happens in the UK. I didn't say all medical oncologists.
Okay.
Yes, that's the
If
case.
we don't
We are
have clinical
discussing
response, of course we send the
international
I think
differences.
you need to
yeah.
understand what an MRI is done for.
Yeah,
if
sure.
your patient is conservable at the start,
Of
and
course.
the tumor is seen on ultrasound scan, then MRI adds no value. If it's a
MRI
borderline surgical decision, where an MRI might swing a decision one way or the other, then it's worth doing an MRI.
Yes.
For example, if we have clinical response and the patient is going to have mastectomy, we don't order any radiologic
Exactly, there's no
imaging.
point. I agree with you.
So it should be decided regarding case-by-case
Yes,
basis,
according
of
to
course. Yes,
patient.
that's the message. And for this case, she had 4 cycles of docetaxel and trastuzumab with pertuzumab dual agent blockage. No complication, well tolerated. Genetics has been ordered and negative for BRCA1 and BRCA2. Clinical exam revealed no palpable mass or axillary node at this point, and it was thought that clinical complete response. So, Darim, again you, if she didn't have complete response, what would you prefer? Would you switch treatment, or what would you do?
Clinical complete response doesn't show us pathologic complete response. You know, in some studies, in I think Neosver's trial, after taxane and dual blockage, the patient went to surgery. The pathologic CR rate was about 45%. But if we use anthracycline and taxane-based regimen before, the complete response is up to 70-80%. So we prefer to complete the treatment, both anthracycline and taxane-based treatment with anti-HER2 therapy before surgery. We don't use
If she didn't
anthracycline.
respond to the first EC, you switch to the taxanes early.
Yes,
That's what the question
That's
is.
the question.
So sorry,
Yes.
but she
If she
received
didn't-
So
first
she didn't respond to the
anti-HER2,
first 2 cycles.
but
Yeah.
she received taxane and anti-HER2 treatment, not anthracycline. She's asking anthracycline treatment.
No.
If she
No. I asked first, the first part of the question asks if she didn't
If she
have
didn't receive
complete
respond
response, would you
anthracycline,
switch? Yeah.
we follow very closely. If there is progression, we switch to taxane and
I think that's the
anti-HER2
question.
early. Yes, sorry.
Yes, thank you. So we have mentioned it, but we have time. What imaging modalities do you prefer to evaluate your response during and after completion of systemic treatment? As you answered some of them, we can have your thoughts, Professor Aribal, at this point as well.
Same,
What
for this
would be-
patient.
For this patient, yeah.
I would go with mammogram and axillary ultrasound, yes. And the ultrasound of the mass as well.
If there is no microcalcifications, do you order mammography again after now?
But she had some kind of microcalc.
For this patient?
Yes.
Yes, I would, because I don't have, my first beginning examination is mammogram, so I should have at the end the mammogram.
I think that regardless of what the mammogram post-neoadjuvant can give you some additional technical information, because you may not always expect the same type of skin flaps, either because the patient has gained weight during chemotherapy or lost weight during chemotherapy, because we can see both. But it is also quite common, I think, that the texture of skin and soft tissues will change.
But
and
in this patient, she's conservable.
yeah, she's conservable, but I'm discussing.
General.
I'm discussing in
Oh,
general.
okay.
That's
Yeah,
the one thing. And
sure.
in the case you see them, you see small breasts without ptosis, and then you see them quite ptotic and shaggy, isn't it?
Possibly, yes.
So I would like to ask Professor Arabal again. She has some kind of microcalcs remain after the neoadjuvant systemic therapy. What is the importance of these microcalcs after NAC? And do we, as surgeons, do we have to excise the whole volume of them?
Yeah, it's a tricky question because we never know if the microcalcifications are still the sign of DCIS or just macrocalcifications where the DCIS has disappeared. So we don't know the right answer.
It's up to us again. Any other comment about it? What do you
So
do in your
you're-
clinical practice?
Let me ask you this question differently.
Yeah.
So let's say with your histology report which said whatever grade 3, ER negative, PR negative, HER2 positive. Your initial biopsy didn't show DCIs, didn't show calcification in the biopsy. And you have 6 centimeters of microcalcification left. Would you excise it all?
You should, well.
Would you?
No,
I have the answer. I
would
just want to know
not.
what you
I would discuss it with the surgeon about, because it's a HER2 patient, and you have the calcifications. Then it means that with the HER2 patients, we see a lot of calcifications with DCIS. So it means that there is DCIS.
Would you?
Actually.
So okay, let me put the question.
And then I discuss. I'm not.
If
with
it changes,
surgeon.
if it changes your plan from breast conservation to a mastectomy, would you do a VAB after the chemotherapy to show that there is DCIS, or wouldn't you just excise it all?
I would discuss it with the surgeon if.
And Andreas, what would you do in that
if
case?
it's going to change everything, yes, why not?
For a patient who is eligible for breast conservation, for example.
So that particular
that
one,
patient.
that particular one was eligible from the get-go without many big modifications in the surgical plan. What we have done sometimes, I'm moving along the line SASHs, and what I know that they do as an institutional audit at the Marsden, for example, that they will go and perform a series of VABs in the microcalcifications. When do I do it? I do it either in the case where the pattern of the microcalcification doesn't make any sense and does not respond to a diagnosis of DCIS from the beginning, or where I will have to escalate surgery. So if a lady that can get away with just an oncoplastic lumpectomy will need a perforator flap, for example, I would venture to more complex surgery just because I can do it.
And just to make it more confusing, let's say that microcalcification turns out to be benign. How will you follow that up? I'm just doing this for fun.
Take into
If it's
account the
benign,
patient. Take
routine-
into account the patient.
Routine follow-up.
And your idea about it? Do you have anything different, Mark?
Yes, very short answer. So as long as you have microcalcifications and you don't have to have clarified the microcalcifications, then you have to excise them. Otherwise you don't get the information.
Sure.
But you can't get the information from the biopsy, so why would you excise it?
Then you have a
You don't need to
sentinel.
biopsy the entire area. You can get a nice VAB from the middle and one corner. That's how all screening mammograms are done that way.
The issue is
You got
the
point.
pathology
Yes,
of the
that's right.
microcalcs. After that, you have to prove that there is
So
some kind of
disease to
tumor
cell-
cells if you excise it.
So we have
That's the
published 10
message.
patients of
Yes,
HER2 positive.
absolutely.
So with more than 6 centimeters microcalcification, it's been published by us, where when we excised the microcalcification in the mastectomy specimen, there was no disease. It was
yeah.
YPTIS0.
So we move on. There are lots of questions. Discussion, you are discussing surgical options. What type of surgery would you recommend for this specific patient? When discussing, you realize that she would like to consider breast conservation, but her husband is hesitant and would have her consider some kind of mastectomy. What would your recommendation would be?
Husband?
Her husband.
Husband, you should send him out of the room.
Yeah, great. That's it. And what would you recommend for surgical option for this lady?
This is the most, it is the easiest, most widely accepted and upfront solution.
But if she lacks breast conservation?
Yeah,
D.
B. Sorry,
D.
I said I heard as D. You said B. Okay. And then I would like to ask some other surgical questions. For example, Ash, what are the patients?
With the husband thing, sorry to interrupt. No.
Yes.
But this is, I think that this has to do with sociological, cultural,
yes,
and other factors that we all meet since we meet diverse populations. I'm just naming it because it has been an issue in Sweden. A surgeon, there was a husband that had different opinions and tried to enforce his opinion on his wife. The surgeon, we are by law obliged to call the police.
It's as you said, something very cultural, and also it's the same in Turkey. So Ash, what are the patient-related factors that affect your decision regarding reconstruction?
Regarding, sorry, if she wanted to have a mastectomy and reconstruction.
Yes, patient-related factors, not about this patient specifically, in general.
Who wants to have a reconstruction?
Yes.
Okay,
What about your autologous reconstruction or implant-based reconstruction? What are the factors that you take in consideration during your decision-making?
The most important preference is the patient choice. So what we do is we bring these patients back to an oncoplastic clinic where I'm sitting there with the radiologist and plastic surgeon. We explain why she needs a mastectomy, if she needs a mastectomy, and then what the options are for reconstruction, any adjuvant treatments, how that reconstruction may impact the adjuvant treatments, if she's going to have radiotherapy, what that radiotherapy will do to the implant, what it does to autologous reconstruction, and then she makes a decision. So let's say if it was autologous reconstruction, I think smoking is not a contraindication for autologous reconstructions. You must remember that. Smoking affects microcapillary circulation, so the problem is never in the breast, the problem is in the DF scar. That is why they don't like to do it in smokers. It's not because the breast flap will fail, because that is a nice anastomosis. It's that the scar will have dehiscence and takes delayed healing, and you then can't, let's say you want adjuvant chemotherapy, that may delay adjuvant chemotherapy. But what they do, and this is the plastic surgery world, Buchu is still around, I don't know if she's still around. No. Okay, so the plastic surgery world is split, especially in the UK. There's certain guidelines with BAPRAS that says 35 BMI for autologous reconstructions. Anything higher than that, you shouldn't offer autologous reconstructions, again, because the abdominal complication risk is higher, not the breast complication risk. So they don't offer that. Then what we do there is for an immediate delay where we ask the patient, which is now, I think I can say it because there's no plastic surgeon in the room, is what they tell the patient to do is put an implant and then lose weight and come back and we'll do an autologous reconstruction. Now tell me if this patient has had chemotherapy, she comes postmenopausal, you know how difficult it is to lose weight. If the patient is ER positive on tamoxifen or letrozole, it's almost impossible to lose weight. So that patient is never going to have an autologous reconstruction. But for autologous reconstruction, I think BMI and smoking are two things. They ask patients to stop smoking. I think what you need to tell your patients is to stop nicotine, not smoking, because patients will stop smoking, they'll take chewing gum, they'll take patch. Doesn't help you. So you have to say no nicotine. Now for implant-based reconstructions, there are lots of things that you take into. So in smokers you can't do. You can do with expanders, but again, the jury is out there whether they do a pre-pec. I would do a pre-pec because again, the mastectomy flap decides the outcome, not muscle cover. So I take both opinions on that. Smokers, you wouldn't do very high BMI, you do a skin-reducing mastectomy. We've published the data on BMI more than 35. The highest BMI we did was 46, we did 40 patients. The only implant that we lost with high BMI was smoker, ex-smoker, diabetic, and BMI of 42. So you can do a skin-reducing mastectomy in these patients, as long as you're careful you don't put too big implants. In these patients, we used to do air inflation, so we used to put implants and then fill it with air. So there's no weight on the skin. And then just remember, if you put air in, you have to remove all the air first and then put saline. You can't take out 100 cc of air and put 100 cc of saline, because the next time you'll never get saline out. I mean air out, you'll only get saline out. So smoking, high BMI, if you've got connective tissue disorders, you can think about that. Any arterial disorders, capillary disorders, you would think about that. But more or less, you would do, if diabetes, again, if it's well controlled. If it's not well controlled, diabetes, very high risk of infections. So there's a lot of things to take into consideration, and ultimately patient choice. And adjuvant treatment. So she's going to have radiotherapy, she's a smoker, then you just say have a delayed reconstruction.
So you mentioned you prefer the prepec or spectral implants. All of you, please.
I am going to be just provocative, and I'm quoting my experience. From 2016 to 2023, I have not done a subpectoral reconstruction. My implant loss rate is 2.4%. We do more than 200 reconstructions a year. And we have not put a single implant subpectorally or dual plane. The only one we have done is by patient demand. So that's the only one where we've done a dual plane, otherwise all my implants are prepectoral.
Great, and you, Andreas?
Only prepectoral.
Only prepectoral. Ever since?
Yeah, we think alike. So
Ever since I came back from Fiona from London.
Okay.
Only prepectoral.
And Mark, yours,
Yeah,
please.
10% subpectoral, 90% epipectoral, and the epipectoral cases mostly since the last 5 years.
5 years. Okay, and do you perform symmetrization procedure for a lady at the initial surgery, or do you wait after the radiation of the other breast or other kind of things? Yes, Andreas.
So what we will in general discuss with the patient, I don't care about radiotherapy that much, in the sense that if you leave the other breast unattended, the problems, the eventual problems of radiotherapy may be serious enough that will discourage the patient from any type of surgery and so on. What we do is that if we see that the patient will have clinically relevant asymmetry, that you could roughly define as, most people understand it when I tell them, you will need your old bra for the healthy breast, and then you will need another bra for the operated breast. We will go for that in the same session. It is easier for the patient. They come back to activities faster. We do not have longer operative times because we work parallel to surgeons. And there is some published data, but we also have continuous audits, because, as I said, in Sweden you have to prove that you are cost effective all the time, that it is cost effective for all the stakeholders, both the state and the patient and everybody. So we would go for that.
And also, I would like to learn your idea or recommendation regarding the expanders. When you use expander, or do you use expander?
Sorry, you go first.
Yes, Mark, please.
So we don't use expanders anymore. We use expanders only in second reconstruction. That means after modified radical mastectomy. We use expanders if we have problems in the OR regarding reduction mammoplasty, so Weiss-Perrin skin reduction. We use expanders, deflated expanders, if we have problems in the OR regarding the blood supply. But in all the other cases we use implants, and for the matter of fact that the radiation of an implant is much better than radiation of an expander. The complication rate is much higher with expanders in comparison with implants. And what we heard in the prior talk with the new expanders, I mean, these new expanders, they are out for 1.5 years, so we don't have really data.
Okay, regarding the radiation oncology, Görkem, is it easy or difficult for you to manage a patient with an expander, or would you like to radiate the implant at the initial part?
The initial part, we always want to radiate the implant, because the dose homogeneity is better with the implant. When we control the areas, especially in the left part, the implant is a better one. So we prefer to radiate implants. Dr. Mark said the complication rates are higher with the expander. In the literature there is some conflict about it, but generally it's in dosimetrically to radiate implant, as he mentioned, is very good.
Okay, thank you. And what about the routine use of ADMs? So we have many discussions about this. What is your routine clinical practice in PREPEC reconstructions and the ADMs?
First of all, I have to confide that I am spoiled, because we are doing 90% breast conserving surgery, and I have good access to autologous reconstruction. So we are talking about a few patients. If I can do something without an ADM, so if I have skin flaps that allow to lift an expander, to lift an implant from the very beginning, I will just go for that. I think that the last time I used an expander in a DTI was an ADM in a DTI was 1.5 years ago. But in general, I think that you have to weigh in some factors for the decision. I mean, there is a tendency. What is unclear for me is the surgeon's views on why are we using the ADM, because I think that if you have a high-risk patient, stabilizing or feeling that you have stabilized the implant with an ADM does not solve problems. You just add one more foreign body. So that's, we have to be a little bit conscious about how we do that. What Brut named about a dermal sling, polyurethane, and a little bit of an ADM is a safer solution, I think. It's more pragmatic anyway. But I mean, yeah, I don't need an ADM to plan and perform mastectomy and reconstruction.
Okay,
So
can I learn your ratios of autologous and implant-based reconstructions at your center, and also your idea about the ADMs, please?
So giving everyone a choice, our implant autologous to implant split is 56-44. 56 autologous, 44% implants.
I'm sorry, and what is your percentage of breast conservation and the mastectomy?
So if you count our patients, because most of them have genetic testing, and we also have a very high, we treat the BRCA, the unaffected BRCA patients, so we have a mastectomy rate of about 28%. But yeah, if you count, all of ours are 28% mastectomies are done in our institution, all the surgeries. Now I can't break down the cancer and the non-cancer, but I know from the top of my head it's 28%. Now, coming back to the ADM question. We again are spoiled in the NHS. We have the ADMs available. Let me just give this to you in a short answer, because we know time is short. So my implant loss rate with ADMs is 2.4%. The only published series that you have is from Cicero Urban, who has done cases in Brazil. His implant loss rate is 11.5%. So it's 5 times higher. If you want to take it, you can take it. His complication rate is 19%. So yes, there is a role for non-ADMs and polyurethane implants. You can use them when you have nice thick flaps. And again, thick flaps are determined by anatomy, not because you leave them thick. That is one thing you need to understand. A lot of pictures that Burcu showed, Mark and me and Andreas were discussing, they're not the fault of the ADM, they're not the fault of the mesh, they're the fault of the surgeon. And you have to be a brave surgeon to say that I messed up. If you don't give a good mastectomy flap, whatever you do underneath doesn't count. If you do a good mastectomy flap, whatever you do underneath, the patient's going to be happy. So you have to learn to do a good mastectomy. The ADMs, in the future, we may probably not use ADMs, and tabbed implants will come, because at the moment you're using an ADM for pocket control and nothing else. This whole nonsense about it takes the weight and it does the weight bearing. ADM stretch, it doesn't do any of that nonsense. Yes, tie loop and Tigger meshes will probably take more weight and will be more inflexible when it comes to that in terms of weight bearing. But what you're doing is you're doing pocket control. If you do a good mastectomy dissection, that means you don't go into the opposite breast and you don't go to the back, and you sit with the footprint. Then if you do an implant reconstruction with a polyurethane implant or with a nice snug, not a micro texture, but a slightly in the middle implant texture, then you should be fine. Again, if I can afford an ADM or I get an ADM, I'd use it. If I can't do it, it's not that I will stop doing reconstructions.
Yes, Mark, is there anything
Yeah,
you'd like to say?
So no, we know that there is no head-to-head comparison between ADM, mesh, and nothing. So this would be a very interesting study. But I think the statistical calculation would never be managed to get such a high patient number to show statistical differences. Regarding what Ash said, this was already discussed. It's not the product, it's the surgeon, and of course the indication. We all remember this French study with Stratus, and then Stratus disappeared from the French market. This was not the product, because the same product was used in other countries. So therefore, we have access to everything we're working with since 2008 with meshes. So all the meshes, all the ADMs that are accessible, we have a higher seroma rate, and this is something what the FDA is discussing. And if you read the protocols of the FDA discussion rounds, then you see that there is a body of evidence growing that we have a higher seroma rate, a higher rate of implant losses. And this is not really compared head to head, of course, but we do have a trend for the measures. But as I said, so there's no head-to-head comparison, and as long as you're successful,
it works. Okay.
And you know, it also depends on history, because in our experience, I love to use Tylu. The problem is the minute you tell the patient synthetic mesh, you know, there were two problems in UK. The most recent being the mesh the women use for pelvic floor repair. And now the government said, come back, let's remove all the meshes. So it's become impossible to sell a synthetic mesh to a patient because they said, no, biologic sounds better to me, I'll go with biologic. So it also depends on your patient population, the level of education that they have.
Yes. I also wonder your opinions regarding contralateral risk-reducing mastectomy.
So
it's
it
the hot
depends on
topic, sorry. Also in the pathogenic mutation carriers and not the mutation carriers. And also your shared decision-making, recommendations, discussion with patients, and regarding tumor biology, for example, or the menopausal status. And what about the oophorectomy? Yep, this is for you, Mark. Oophorectomy, yeah. No,
Mark,
Andreas, please.
Take the oophorectomy.
Ask the gynecologist for this.
well, so I could give a lecture right now, so this is a real...
Quick!
No, but we know from the last analysis from Hemskill-Garretson that it makes sense to remove contralateral breast. There we have an overall survival benefit in the affected patient. Then we had the carrier study presented in San Antonio, where we had this idea of BRCA1, BRCA2, yes, but PALB2 endocrine negatives. That means estrogen receptor negative. Makes sense to take the patient into the shared decision-making process to tell them, well, it makes sense to remove the contralateral breast. So since we have this data, we recommend to remove the contralateral breast in an affected patient. But the whole process takes really ages. So I talked with these patients 1.5 hours first round, then another hour second round, and then we have to talk about implant surfaces, BICL, sub-pack, pre-pack. We have to talk about ADMs, meshes, and so on. And we have to talk about bigger, smaller, reduction of the skin and all that stuff. So I mean, this takes really ages, and this is the very big advantage for neoadjuvant treatment and doing the monitoring by ourselves, doing the talking by ourselves. So if you see the patients every 2 chemo cycles, you can talk to them, you can talk about everything, and then when the treatment is finished, you're done. You have the whole strategy done. So this is a big advantage we have, I think.
Okay, thank you. And Andreas?
So when we are discussing contralateral mastectomy in a cancer patient, we just need to be aware, evidence-wise, that the only reason to do it is if you have a gene mutation carrier, the genes that Mark mentioned, and the CHEK2 split variants. These were the genes that had a higher hazard ratio. But the reason you do that is because these patients have a higher risk of getting another cancer in the future, and especially for the BRCA1 and 2 genes, these are genes that have the risk of that other cancer being a cancer that will require chemotherapy again by 50 to 65%, depending on the index cancer and so on. Does it prolong survival on randomized data? There are no randomized data. Is there any clear evidence that it will prolong survival? No, there is no.
Yes.
The index cancer is what is going to define the patient's destiny, unless the newer cancer, the second cancer that comes 10 years later, is much more aggressive. So we have to be very clear in the discussion about what the gains and losses are and what are the trade-offs. And this is a very complex discussion, I agree. I recently had this patient from whom I learned a lot, because she had one of these CHEK2 mutations, and it was detected during neoadjuvant chemotherapy for an ER-negative HER2 positive tumor. So I told her that your relative risk is approximately 40% higher in a lifespan and so on and so on. So she came back to me, being a mathematician herself. She said, yeah, but I understand the relative thing, but I need to know the ground risk I need to know the absolute risk. So this is where the clinical geneticist could give her a complete answer that was kind of signed and official. And the population risk for a contralateral cancer in a 62-year-old was 7%, 7.2, and for her it was 10.9%. And she said, it's not worth it. So this is something that needs to be tailored.
Yes, Ash, please.
Very complex discussion. Agree with everything you guys have said. Now the question is, when would you recommend it?
Yes. Sure.
If your risk, let's say you have a triple negative patient with a very poor response in the breast who is 6 nodes positive. Unless she's having a DF reconstruction, which you can only use once, and she's suitable for a bilateral DF, I would not recommend a contralateral
Yes,
mastectomy.
sure.
So the risk has to be balanced in terms of your prognostic risk versus the competing risk of cancer, which is annualized at 2% per year. So if you live for 10 years, your risk of getting a breast cancer is 20%. But if you have a triple negative breast cancer with 8 nodes positive, your risk of getting metastatic disease is probably 30 or 40% in the next 5 years. So you're more likely to die of metastatic disease than get saved because of the other breast cancer. And also your risk, remember, if you have chemotherapy for one breast, your risk of contralateral breast cancer in one patient is reduced by about 30 to 60%. So it's no longer that 2%, it's 60% of 2%, which comes down to 1.few%. So you have to weigh in balance what is your risk of what you're dealing with now versus future risk. And if the patient says, I just want to have one surgery, okay, you can do it. But as long as you explain the risk, because all this is important, again, as you remember this one patient who will always come back. So we were sued by one patient because we did not tell her that her risk of contralateral breast cancer is X%. We did not put a number. We said you're at a high risk of contralateral breast cancer, but it's not going to save your life. But because we did not say the number, we lost the case.
Also, we should be aware that the patient's adjuvant treatment should not be delayed regarding our risk-reducing surgery, because these surgeries also from the United Kingdom, the IBRANET study, they are not complication-free reconstructions.
So if you read the IBRANET study, half the centers in UK should be closed by their own guidelines. Because the guidelines of ABS say anyone who has 5% and higher complication risk, you shouldn't be doing it.
But
IBRANET complication risk is 19%. So 90% of the unit shouldn't be doing reconstruction.
Of course.
The learning curve is very important. So if you look at the BRIO study, which is also published, the BRIO study was published in a very, very good journal. And one of the top journals, and I don't need to name it because I'll get sued otherwise. And we sent a letter back to the editors. So there were people who did 2 reconstructions in their whole life, and both of them failed, and they were in the BRIOS trial. If you accept all this, then
Andreas.
I can. I'm an editor myself. I can say the journal. It was Lancet Oncology that published that, and it was the JAMA family that published the Stockholm study that they did together with Oxford, and they have the same problems. So when we are talking number of implant loss complications and things like that, you can actually not venture on to design and perform a study if you have not been able to stratify or make sure that the surgeons that will be doing the procedure can do the procedure. And this is the reason for which all these randomized trials will never tell us the truth, because centers with high volume, like the Marsden guys, I mean, this Ash and his team have one of the largest numbers in Europe, I think, when it comes to implant-based reconstruction and experience. I don't think, now I'm kind of telling, but my information says that it is not that nobody offered you to join these trials, but you said that this works well, we don't want to risk it.
Yes, okay, we have to move on. So when do you perform operation after neoadjuvant therapy? What is your optimal time? Within?
Anytime after 3 weeks and before 6 weeks.
The same?
Between 3 and 6 weeks.
Okay, then we move on. She had breast conservations, she had cavity shavings, and she had a dual agent technique with sentinel lymph node biopsy. 4 sentinel nodes has been gathered. The clipped one was the second sentinel node. We can see it over here, I guess. Yes, the clip in the node. And in your routine clinical practice, I think, do you perform dual agent technique for sentinel lymph node biopsy, or which techniques do you prefer?
We use SPIO as a standard of care. So patients that are clinically node negative and maintain clinically node negative, we don't use a dual tracer. SPIO will do. For patients that are clinically not positive and convert, where we will attempt target axillary dissection or sentinel lymph node biopsy, we have trialed dual tracer, so MAC trace and isotope, since the literature was isotope based. Our current results that will be published soon suggest that the SPIO may do the work by itself in terms of nodal retrieval and detection rate.
Great.
But currently dual tracer, isotope based with MAC trace.
Okay, and yours? Ash, the same, and
Dual
Mark?
tracer.
Dual tracer.
You must
Okay.
understand when he talks about SPIO, he's talking about SPIO gives you two benefits. It gives you not only directionality, which is what your isotope gives you. When you hold the probe, it tells you where the node is. It also gives you color. So it's gray and it gives you direction. So SPIO does two things in one dye, whereas you need a blue dye and an isotope to do the same thing. So that's why he's talking about SPIO as doing both the stuff as one injection.
Okay, do you perform intraoperative pathologic evaluation for the breast margins or the lymph nodes, Mark?
Yeah, but we are a special case, so we're working with diffusion-weighted MRI and EOR with a clear coast technique, and this within trials, but sort of daily routine. So, but this is done for an intraoperative margin assessment, but not in this case, because this case is pre-treated with neoadjuvant chemotherapy. We only use this in upfront surgery.
Okay.
And I think this is the biggest problem we have. So frozen section in pre-treated patients and imprint and so on. This is really problematic.
So do you perform frozen section in our view for the margin assessment? No. And the lymph nodes after neoadjuvant chemo? No. Okay.
If you want to do lymph nodes, you should do OSNA.
Yeah. So, Professor Kaya, I would like to ask you, what would you recommend surgeons as a pathologist regarding intraoperative evaluation? I mean, the frozen sections, imprints, or those kind of things. Do you suggest, recommend, or not?
No, because
Okay,
of the fibrosis, we wasn't recommend. It's very complicated to decide whether there's tumor exists within the surgical margin, and it's complicated.
Thank you. So her surgical pathology is small areas of in-situ disease in the breast without invasive component. Margins are negative and no metastasis in the lymph nodes. So can we say that she is pathologic complete response?
It depends on your definition. Which definition you use. Whether you say YPT0 or YPTIS0.
Yes, sure. I would like to learn the medical oncologist's point of view for this patient on a DCIS left, HER2 positive. Do you think that she had complete response, or?
She doesn't have invasive disease, so it's complete response for us.
Okay, so should we repeat staining after neoadjuvant chemotherapy, Professor Kaya? Might there be
yes.
any changes in the markers?
Yeah. Especially hormonal status may change, and some alterations may occur. I think it's about 30% for PR and approximately 20% for ER, and HER2 may also change in either way, or negative to positive or positive to negative, about 15%.
But this is very important, so that changes, but don't take this into account for your post-neoadjuvant treatment strategy. So because there's really good data out of the Catherine study that if the HER2 receptor disappears afterwards and you stop your HER2-directed treatment, then this is the wrong decision.
Yes,
No, it will not change our treatment.
Yes.
Just to point
It
this
was
out.
the second question for the medical oncologist. Okay.
But I agree that according to guidelines, I have to do it.
Okay.
Okay.
So a quick question: when would you consider recommend re-excision relevant to margin status for patients after NAC? There is no income tumor is enough. We are all agree on that.
No, there's one more.
Yeah, you
So
say.
if you look at the SSO Astro consensus, if you have spotted, isolated cells all over the tumor bed, but not at the margins, you will go and do a re-excision of margin.
Yes, that's it. Okay, that's the guideline recommendation. And we move on. Would you recommend a completion of axillary lymph nodes decision? And when? This is the scenarios for postoperative MDT meetings that we are usually encounter. For example, if you have 1 out of 2 sentinel nodes or 1 out of 4 sentinel nodes.
I think we covered that this morning. So post-neoadjuvant chemotherapy, you have a binary response, either no cancer or any cancer. So that's what makes the decision, and we know that I think it was very clear from the morning talks. that you cannot extrapolate the findings of Z11 or Amaros or all the other Synodar 1 trials or whatever to the setting post-neoadjuvant.
So all of you proceed axillary lymph node dissection currently according to current guidelines.
Yes,
okay?
we recommend
That's
it.
it.
We have patients that will decline that.
Yes.
And we can be more flexible in the discussion, because if you have a targeted axillary dissection with some cancer in the index node and a total of, let's say, 5, 6, but negative, yeah, you discuss it, but formally you have to recommend it, and until data suggests otherwise, I think that it should be discussed only as an exception to the rule. We cannot forward practice just based on opinions.
Okay, I proceed. And to find a marker in the axilla intraoperatively. You're aware, of course, you use some kind of MACSEED, and if you use, any of you use metallic clips, for example, what do you do to find them? For example, we use metallic clips in
Intraoperative ultrasound.
Intraoperative ultrasound, yeah, routinely. Okay. So, to Professor Aksu, regarding radiation therapy, with this pathologic result, would you recommend radiation therapy after neoadjuvant therapy? She has one axillary positive node before the therapy, and after that, it is complete response.
As we discussed in the morning very precisely, since the patient had the clinical M1 disease, although the pathological lymph node is negative, we have to, according to guidelines, we have to irradiate this patient, the regional lymph nodes. But as we discussed before, there will be a very big debate about this, I think, and I think in a few years we will also stop like surgery to irradiate. But nowadays, according to guidance, we have to irradiate.
Is there any role of tumor biology regarding your radiation therapy, or a future view of tumor biology regarding radiation oncology?
As you know, we have a group which we can omit irradiation. It's 65 or 70, 65, 60 or 65 years old. Hormone, both estrogen receptors are highly positive. As we can say, luminal type A patients. Then maybe we can discuss with the patients, in luminal type A patients with no lymphovascular invasion, no extra bulky lymph node at the presentation, no in luminal type A, and these patients with no high risks we can discuss, but according to guidelines we have to irradiate.
Okay, thank you. She had the whole breast radiation and the nodal basis after discussion.
Can I ask another question? So in this patient, would you boost the tumor bed or not boost it?
The boost is also a matter of debate, because
that's why I asked the question.
According to boost, we have to give the boost to the patients with the high risks. So this patient, we can't describe that this is a patient with a high risk, but because it's not a triple negative patient, I have two positive patients, estrogen is limited but positive. So I don't have a correct answer, and in the literature there is not a correct answer to it. This is a very discussable. In this patient, maybe I would omit the boost. Good. Because a small tumor, no lymph node treated, so.
But I just wanted to bring out that it's debatable. Still not, it's not clear.
Yes, we have to move on. Thank you. And after that, what are the options in pathologic partial response? Professor Çabuk, what would you recommend for her adjuvant treatment?
If we have partial response, not complete response, we go with TDM1 for 1 year adjuvant treatment after surgery. If we have complete response, we go with trastuzumab.
So she had her adjuvant therapy completed, and she's without any kind of disease recurrence or metastasis after 1 year. And after that...
What did you do to the axilla? What did you do to her axilla?
Axilla?
Did you do a sentinel biopsy and leave it, or did you do a clearance?
No, the sentinel lymph node biopsy and discuss with the patient and then radiate it.
Okay.
not axillary lymph node dissection. So I couldn't give you the numbers of axillary lymph node dissection yet. How would you design your follow-up for this patient with a complete pathologic response after with HER2 positive disease?
In MRI.
Routinely, what is
Only-
your follow-up suggestion in your countries?
So classical follow-up is an examination of the breast by the physician every 3 months, the first 3 years, then accompanied by a mammography once a year, and this is the schedule for the first 3 years, and then you see the patient every 6 months for ultrasound and physical examination, and mammography stays for 1 year, and this should end after 5 years, but in fact, I mean, this continues, especially in the endocrine responsive tumors, because then we have the late recurrences.
Okay, do you have an opinion about it?
So high-risk disease we would see physically, but most of our patients now go into remote surveillance. So they get a mammogram appointment every year, and the patients make an appointment if they have any symptoms to come in. They're driven by the patients. We don't make an appointment to physically examine them or give them ultrasound scans or anything of that sort.
So the formal recommendation in Sweden resembles that of the UK. The only difference, I think, is that we are offering annual mammograms for a total of 10 years, and,
Oh, yes.
and that can be modified, that is the modality, depending on whether mammogram failed. So a very particular minority of patients that were mammogram negative, but disease was detected on MRI, for example, will be followed with the respective modality.
Or if the breasts remain dense after chemotherapy, then we would do a contrast-enhanced mammogram follow-up or MRI follow-up. So it all depends on how evaluable the breast is.
Okay, we have only 10 minutes left, so I would like to close this session and have other 4 cases, if we can have a quick shots in hot topics in breast cancer. So if we have a premenopausal de novo oligometastatic disease with a lady who had a T2 disease, biopsy proven, IDC, G2, ER, PR positive, HER2 negative, Ki67, 50%, and she has only osteolytic lesion in the upper segment of the sternum, and received dose dense AC 4 cycles, followed by weekly paclitaxel. And do you have any objection or different suggestion for the presented treatment for this patient? After that, she had mastectomy and sentinel lymph node biopsy.
What did the post-PET show? Post-treatment PET show?
No, this is the pre-treatment, and post-treatment PET show nothing about it.
And you went straight for a mastectomy?
Yes, they, not
Yeah.
we.
Oh,
this
they.
is a scenario.
Yeah, I wouldn't have done surgery.
I wouldn't have done surgery either.
Yes. And then, with this data, would you radiate the thoracic wall or the sternum in the radiation oncologic point of view? Yes, this patient.
No. Just, you mean the met? The bone met?
Yes,
Would you radiate the bone met?
bone met, only bone
The
met.
bone met, would you radiate? Disappear, there's nothing. Yes.
So only an indication is pain, of course. So
Yes.
if you have pain, otherwise you go for denosumab or
So you
bisphosphonate.
do not operate any oligometastatic disease?
No, it's not that do not operate.
So
It's when to
for-
intervene.
When do you operate a patient with oligomet? That's the question.
So currently, we will discuss surgery in patients that have induction chemotherapy, good control, and have stable disease in the breast, but all metastases have disappeared with favorable subtypes. That's the one case. And the other case is that we have an ongoing randomized control trial, which is called the Brecklim study. These patients, that the minority of metastatic breast patients that will present with a solitary liver metastasis, if they are assessed and enrolled in the trial and undergo wedge resection from the liver surgeons first, then they will get therapy and they will be operated. But this is just a trial.
But it's very crucial. So if we have to think about the treatment, this is an adjuvant treatment strategy regarding the chemotherapy. So we would never do such a chemotherapy as long as we not have the idea for a second adjuvant chance, but no one of us knows that. And for that reason, the osteolytic lesion has, of course, to be clarified. it's not just a lesion that can be diagnosed by CT scan or whatsoever. It's the only metastasis, and you have to clarify that.
Of course, yeah.
Biopsy or excise that thing and so on.
Yes.
And the Florence trial was published just 3 days ago and showed that you can actually go for focused radiation therapy, high intensity radiation therapy, if you, stereotactic, if you do not want to intervene in any other way. But this is a patient with stage 4 disease. Stage 4 disease remains stage 4 disease. The bulk of the trials that used induction chemotherapy showed no difference. And that's where the evidence weighs towards.
Yeah, so we would have indicated a CDK4/6 inhibitor in combination with an endocrine treatment and no surgery, and but in the biopsy, of course, before of the stroke.
So we are running out of time. We can have a few questions from the floor. Yes, please. Can I get a microphone to...
This is really very straightforward multidisciplinary meeting, just a guideline, no expert opinion, so I'm not satisfied very much. Thank you.
We have to follow guidelines, not only 1 or 2 patients.
I agree, because we have to follow guidelines. Unfortunately, eminence-based or evidence-based, we have to talk evidence-based. So I thank all the faculty for their great... Sorry. Hocam buyurun.
Obstetric side, but whose mission is to inform patient for the fertilization preservation in your country?
So we have a counselor who does that. We send them to the assisted conception unit, and they offer all the possible options. And the patients don't want anything like embryo preservation. So it depends on whether they have a partner, they don't have a partner. If they're with a partner, we do embryo preservation. Otherwise, we do ovarian cryopreservation. It has the least success, but that we offer it. Or we offer things like ovarian cooling and chemical castration before chemotherapy.
Same here. Yeah.
Thank you very much for the information.
Okay, I'm closing the session. Thank you for your contribution to the panel. It was a great discussion. Thank you very much, and all the attendants. Çok teşekkür ediyoruz. Sağ olunuz. Thank you. It was great.
Thank you.
We must have some kind of picture.
Yes,
just wait. A picture. Hocam görüşmek üzere. Yanınıza sağlık. Çok teşekkürler. Yes, thank you.